Desde las modernas instalaciones de la Universidad de Santander, en la capital del departamento de Santander, la ciudad bonita de Colombia, la ciudad de los parques, transmite UDES Radio Bucaramanga, su emisora online, estación de radio al servicio de sus oyentes. UDES Radio Bucaramanga, su compañía ideal en todo momento. UDES Radio Bucaramanga, emisora de la Universidad de Santander UDES, donde está su mejor proyecto de vida. 37 años contribuyendo con la formación de la juventud colombiana. La calidad nos une. Universidad de Santander UDES, su universidad internacional.
Muy buenas tardes. Yo venía a presentarles un saludo de bienvenida. Yo me llamo William Reyes Serpa, soy el decano de la Facultad de Ciencias de la Salud de esta universidad, Universidad de Santander, y soy el director del programa de medicina. Para nosotros, adelante doctor Velandia, para nosotros es muy importante verlos a ustedes aquí reunidos en un tema que comentábamos con el doctor Vargas y con el doctor Duffau. Es un ejercicio, dijéramos, de región, de país, en la medida en que van a estar ustedes dedicados a un tema que, aunque tiene ya algunos años de estar en utilización, está rompiendo paradigmas en estos momentos a nivel mundial. Desearles el mejor de los éxitos y ofrecerles nuestra universidad como su casa. Siempre siéntanse aquí bienvenidos, de manera que muchos éxitos. Muchas gracias doctor Duffau por estar con nosotros. Doctor Vargas, usted como siempre se lleva a cuestas todas estas actividades que rinden un tributo muy grande al engrandecimiento de la neurocirugía y en últimas pues de la atención que se le va a dar a nuestros pacientes. De manera que muy buenas tardes, bienvenidos y muchas gracias por acompañarnos.
Alguien me está diciendo que la resolución está mala. La internet de él. Debe ser su internet porque aquí está muy bien. Bueno, primero que todo, quiero saber si alguno necesita audífonos para inglés. ¿Alguno necesita audífonos o todos entienden inglés? Audífonos. Dr. Velandia, welcome please. Come here. Dr. Velandia is one of the speakers here, neuropathologist. Dr. Duffau, I want to meet Dr. Velandia. You have the microphone to say just hello. Por favor, entonces los que necesitan audífonos, ¿alguien necesita audífono o no? Que no supe. Solo dos, del resto todos inglés. Muy bien. So, better to speak in English. Excuse me about my English, but I want that Professor Duffau try to understand me, what I'm telling you. And the goal of this meeting is bring this great neurosurgeon here in order to try to learn a little bit about brain tumor surgery and especially his philosophy. So at the beginning, I just want to show you what was the lesson learned in Montpellier when I was with Dr. Duffau in February past year, trying to understand how it's possible to take a lot of the brain without damage the patient. And that is the reason why it's here, in order to teach us how is possible to improve the quality of life of the persons with a brain tumor. These words, maximal safe resection, means that we need to take most of the tumor and most of the brain possible that it could be included within the tumor in order to try to cure this disease, brain tumors, intraaxial brain tumors. We know that right now the statistics say that 2 from 10 people diagnosed with brain cancer will survive, while people with leukemia or breast cancer, 9 to 10. So we are really back in order to really improve the quality of life and the survival of the patient with brain tumors. And we need to do something. And this person, Dr. Duffau, is trying to change that curve, if you see the statistics that we are going to see this afternoon. These words, functional, preventive neuro-oncology. Preventive neuro-oncology means that prevention is a word of act of stopping something from happening. Maybe we can stop a tumor to kill the patient, and we are going to learn that this afternoon, something about that. I like also to show these words of Dr. March, say that as surgeons we need to be careful with the patient, with the function with the patient. So it's important to keep in mind that we cannot harm a patient during surgery, and we need a balance between complete resection and morbidity, and that is why the ideal is do complete resection in most of the tumors. For example, for low-grade glioma, we need to take most of the tumor, and there is a concept of Dr. Duffau that is called, no, I don't have, yeah? A concept that is called supratotal resection. And we are going to hear about that, supratotal resection. What does mean? What means supratotal? It's not only the tumor, but the tissue around the brain that maybe has some cells, cancer cells. And for that, we need a menu of things to do things. So this is Dr. Duffau trying to mix many things in order to improve. Yesterday night, trying to do something. So what kind of menu? A menu based on the patient. So we need to recognize a patient. This is an age, a Karnofsky, the occupation, and the most important thing is the quality of life of the patient. The most important thing that we need to keep in mind is to preserve the quality of life. This is one of his main teachings. Of course, we have some surgical consideration always when we plan to do the surgery, the accessibility, the resecability, but the quality of life is the main goal. Of course, resect the tumor, but preserve the quality of life. There is a menu based on the surgeon. This is, we asked the person that we were there at the time, and it's different if I do the surgery than Dr. Duffau doing the surgery. Of course, we need to recognize our experience, our confidence, our training, our learning curve. But Dr. Duffau says something. If we dedicate only to brain tumors, of course we are going to improve the goal to do the best. So Guzman, for example, in Cali is dedicated to tumors. It's an example. He's a crazy man. Everybody criticizes him, but he's dedicated to brain tumors. This is an example in Colombia. So we need to do that in order to really improve the curve of the longer survival with the best quality of life. So the surgeon is important, and of course we need menu based on the patient, menu based on the surgeon, of course menu based on the institution. If the institution doesn't have the main thing that we need, and the main thing that we need is monitoring, but it's not a lot of technology, as you can see after the talks of Dr. Duffau. Some technology, of course monitoring is one of the best things that we need to have. Some ultrasound and neuronavigation, intraoperative MRI, maybe is not necessary in many of these tumors. So this preventive neuro-oncology needs, Dr. Duffau says, not only evidence-based medicine that maybe is a mistake, but individual-based medicine. Patient by patient, try to study the patient and to see what is the necessities for that patient. So the goal of the treatment should be increase the medial survival, improve the quality of life with preservation of cerebral functions. Those are words that you are going to hear this afternoon, and the impact of the surgery with the wake surgery, with brain mapping, with individual approaching, of course, are going to preserve the quality of life with the mapping, brain mapping. This is a brain mapping. So normally he open a big craniotomies, try to show where are the cortical places, but also the tracts, the connections between many of the places in the brain. And this is the most important thing, not only to know where is the Broca area, where is the motor area, but also the connection in the subcortical area. And this is the most important work of Dr. Duffau, the tracts. And we need to pay attention today and how we can reach and know where is the track, and as a neurophysiologist try to learn how to really detect where is the track. Not only, okay, this is Broca's area, that's it. Dr. Duffau has a book for the population that is called The Error of Broca, which is mean that maybe we think that the Broca area or whatever area is here, but it's changed many times. It depends of the patient. I have a small video just for show that we take most of the weight of Dr. Duffau of doing surgery. We try to teach many people how to do it, how we need to take the patient, what is he doing in many of our surgery after I come in from there, and we apply some of the concepts. Of course, we need to learn more and more and more in order to improve our surgeries. And of course, we do some resections. We try to do similar kind of resection. This is a left frontal case. And I want to show you the cavity, and I want to see something that is in their books, that you see this kind of resections with the tracks of big cavities, big resections. Sorry, I took the picture from your books, but this is the kind of surgery we need to do, really big surgeries with brain mapping. So, Dr. Duffau, welcome. I am so happy to have you here. It's an honor, an incredible honor to have one of the main neurosurgeons around the world talking to us, to Bucaramanga's neurosurgeons and Colombian neurosurgeons and neurophysiologists and many other people. You are going to be in this meeting in Bogota in 2021, try to do something like this. So the recommendation for today is please participate, interrupt anytime when you like. The schedule you have already. We have 4 talks, I think, and then some videos, cases. We have a break at 5 p.m., around 5 p.m., and then another 2 hours of some talks, and then we have a dinner tonight for the participants. I think you have the microphone.
Thank you so much. I'm very happy to be here for the first time in Bucaramanga, in Colombia. And I'm so happy also to see that what we discussed about 1 year and a half ago became possible. In other words, in fact, everything more or less is possible. So that means that it will be the topic of the talks today, to speak about my experience about more than 1,000 awake surgeries, especially in low-grade glioma, in order to arrive earlier and earlier. And the first topic will be why to operate, of course. Then I will show results regarding the neuro-oncological issues. Then the second topic will be not how to operate, but first of all, how to understand the brain itself, because we are not operated on a tumor. At least it's not my philosophy, because I will do everything in order to better understand the natural history of the tumor before to go to the OR. But within the operating theater, the goal will be to see the brain. And then finally, we will see how I do it with videos and so on, and you will see that it's very easy to understand why we operated on and how we were able to deal with the brain in order to achieve very good results regarding at least the functional issues, knowing that even if we changed radically the natural history of the gliomas, we are not still able to cure them. So I hope we will continue to improve altogether. And to finish, we will have interactive discussions with cases I will show you, and you will tell me what you would propose today in order, in your country, in your philosophy, in your culture, maybe to change a little bit some practice or not, according to the results, because I believe, in fact, just on results, data, statistics, facts, objectivity, and not just, okay, I have this habit for many years. I love to challenge dogmas in order to try to improve the results for the patient. And this is the reason why I have this unique series with prospective collection of data. And even this morning, I answered to many emails to my patients because I am connected to them 3 months following surgery until 23 years following the first surgery I did in a girl still alive and enjoying a perfect normal life. And this is the goal, to my opinion, to be helpful for patients. So this is the reason why I was disappointed in oncology after 20 years, because speaking about the classical journals of oncology, most of the time, I mean in 95% cases, the most important is just median survival. And I will show you that we tripled more or less the median survival. So it's not against the median survival, what I will show you. But it's first of all for the quality of life. Because I will tell you a secret, if the patient is well, that means that the patient is still alive. And the reverse is not true. And young oncologists have not understood that. What they want is just to maintain patients alive, whatever the price. Of course, it's a philosophy. But you can ask to the patient, do you agree with that? Or maybe you would like to enjoy a normal life. Maybe sometimes. Speaking about low-grade glioma, I continue, despite this slide, which is very old, to meet every week in my practice, almost every week, because sometimes I'm traveling, patients coming from different institutes in France, in Europe, or from the rest of the world, 5 continents, we just wait and see because the tumor was stable. Really, the tumor is growing. In all cases, 100% cases. This is the reason why it's a tumor, otherwise it's not a tumor. And then the tumor will become malignant and we will say, oh, it's time to do something. No, it's too late. The patient will die. No, we have now many possibilities, you know, technology into the operating theater, we have targeted therapy, we have vaccinotherapy. No. In 3 years, patient will die. It's too late. We killed them by doing nothing. So we can also consider that it's not a benign tumor. Example, this is a stable tumor. It's exactly what I have seen recently. And I'm very aggressive sometimes because I continue to have to explain to the patient coming to meet me many months or many years later, finally with the first and the last MRI, why I continue to have more and more seizures. And they told me that the tumor was stable. And then I have shown the first MRI, the last MRI, and the patient doesn't need to be a specialist in oncology to say that it's growing. Yes, it's a tumor, but they told me it's stable. I don't care. The tumor is growing. So please do volumetric assessment by yourself. It will take 2 minutes. You will be objective. It's never done. Why? We will speak about intraoperative MRI. I was in the San Francisco meeting, CNS, a few days ago. I gave a lecture during the general topic session, especially speaking about low-grade glioma surgery, of course. And I have visited, as every year, you have intraoperative MRI, you have your navigation, billions of dollars. But you need just 2 minutes with nothing, with the finger, in order to say to the patient the truth, you have a tumor, it's growing. But because it's not done, in the vast majority of cases, finally, more or less 4 to 5 years later, you will see an announcement, and you will say, oh, finally, the tumor became malignant. Oh, really? I thought it was a benign tumor. No, but don't worry, because now it's malignant. But we have so many possibilities thanks to the development of oncology. No, 3 months, 3 years later, the patient will die. And we killed him. The second point, we have the habit to say, my patients are well, because I am a good surgeon. Forget the fact that we are surgeons and oncologists. We are telling the patient is well because he had just 1 seizure and finally we discovered the tumor. No, forget it. The patient is not well. He has a brain tumor. Please do an extensive neuropsychological examination and you will see that in more than 90% cases, more than 90% of cases, the patient will have already some degrees of cognitive deficit. And we don't want to be aware about that because only 10% of patients I can meet in Montpellier had before to come to Montpellier neuropsychological examination. So that means that in 90% cases, oncologists, surgical oncologists, medical oncologists, what you want, don't care of their patient because they don't want to know that the patient is not well. But if you spend 1 hour with him, he will tell you, I am a little bit more tired. Sometimes I have to repeat more or less. I was not so efficient during my job. At home, I a little bit more irritable and so on. Oh, don't worry, just because you're becoming older. No. It's because you have a brain tumor. And you can believe or not, but this deficit is not related to the location of the tumor within the brain. This deficit is related to the invasion, the migration along the white matter tract. The limitation of neuroplasticity is the connectivity of the brain. This is the reason why the second talk will be dedicated to how the brain is processing. Because we do not treat a tumor. We are treating a brain disease, which is totally different. It's not like the lung. I can remove it completely and the patient is cured. We can try with the brain. Once again, the patient will not enjoy normal life. So he will not be happy. Limitation of neuroplasticity, first step, seizures. The brain will say stop. So when you meet a patient with seizure, that means that his brain already reached the limitation of neuroplasticity. So he's not well. So please do cognitive assessment. It takes 3 hours, but it costs nothing. Once again, volumetric assessment, neuropsychological examination, suddenly it's not a benign tumor, it's not stable, the patient is not well. And suddenly we changed the paradigm just based not on what I think, but based on the truth. It's never done. Please explain to me why. We know that if the tumor is bigger, and it has been initially demonstrated by Mischberger, we were on together a few days ago, then the risk of malignant transformation is increasing, which is intuitively understandable. I mean, more we have billions of tumor cells, more the risk of the genetic events we don't know yet will lead to malignant transformation. So the goal is to reduce the volume, and again and again and again. And you will see that the goal is not just to say, we will do surgery in 1 month or 2 months. The goal will be we will continue to treat you regularly all your life by doing surgery, second surgery, then chemotherapy, then third surgery, then radiotherapy, and then you will continue to live normally with a chronic disease, because we will transform this tumor, killing patients within 6 to 7 years in a chronic disease with more or less 20 years of life. And once again, a normal life. But what is very important is also to calculate the growth rate of the tumor. I will tell you a secret. When I say to a patient, if you have a tumor growing faster, the prognosis is worse, they can understand that in 99% cases. New oncologists cannot. I don't know why. Because it's not in the WHO classification, in the RANO criteria, and so on, to see if the tumor is growing fast. When you do the diagnosis, everyone here can understand that if the tumor is growing slowly, the prognosis is better. So please calculate the growth rate, and to do that, you have just to benefit from one MRI, a second MRI, to do the volumetric assessment. We spoke about that 2 minutes, twice, and to calculate the growth rate. And then you have the diagnosis, which is, in fact, better, more reliable than the WHO classification, whatever the WHO classification, because, in fact, just neuropathology or molecular biology is a part of the history, while the growth rate is the absolute truth of this tumor in this patient at that time. And this is the reason why we demonstrated that, of course, it was related to the median survival, but independent of the molecular pattern. You can have growth rate very slow in patients with IDH1 wild type. So that means that wild type means nothing. We published recently 2 papers, one in the Lancet Oncology on behalf of the European low-grade glioma, and one of my series regarding just IDH1 wild type. 20% of them will have a very poor prognosis, glioblastoma. 80% of them has a very slow growth rate before and after surgery. So that means that 80% of people today, with or without surgery, but because the diagnosis of wild type and molecular glioblastoma, will benefit from chemoradiotherapy for nothing. That's good to be irradiated, just for fun. It's very good for the quality of life, especially for the long-term follow-up, because I will show you the impact of radiotherapy on the connectivity. Once again, we are not treating the tumor, but the brain of a patient. Of course, if psychological examination are never done, of course, if we're not asking to the patient, do you work? Of course, we will say, yes, he's depressed because he has a brain tumor. No, 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 no. It's related to the fact that we did something wrong into the brain of the patient. And I will explain that. The WHO classification does not recognize that the tumor is heterogeneous. And I will show you a paper we will publish recently in 1 month in Neurology with resection of macrofoci of grade 3 glioblastoma within a low-grade glioma. And what we did after that is no treatment, no chemoradiotherapy. You will see the median survival. Why? Because we removed foci of malignant transformation. It's not glioblastoma. But according to the classification, if you have one focus of glioblastoma in the middle of a big tumor and you did a complete lobectomy, it's a glioblastoma. So again, we have to give a STUP. Why? 95% of survival 5 years later without chemoradiotherapy. So we have to call cat. And, of course, we have not to continue to say, oh, this is a benign tumor, and we will wait for malignant transformation, and at that time, we will do surgery, whatever the price, because otherwise the tumor will kill the patient with a STUP. And that's it. And finally, if the patient died, we cannot ask for the impossible. I started by telling the impossible does not exist if we are rigorous. And first of all, we have to be rigorous with the pre- and post-operative evaluation of the extent of radiation. After 23 years in this field and more than 1,000 surgeries just for low-grade glioma, I'm not telling after surgery, oh, I think I believe the tumor. What means I'm not in the church. I want to see the post-operative MRI, the flare, and to do the volumetric assessment by myself and some other one in order to be objective. And suddenly, if you take in the literature papers with objective evaluation of the extent of resistance, there is no controversy anymore. In all cases, you have an impact not on progression-free survival, which is just a psychotherapy of neuro-oncologists. I mean, the patient doesn't care. What he wants is to live longer and better, but on the survival directly. And it has been, again, supported by meta-analysis recently published, probably you have read it, demonstrating that growth total resistance had an impact on the survival. Early radiation was not associated with decreased mortality. It's not my view. It's meta-analysis. We love evidence-based medicine. You have evidence-based medicine. Early radiotherapy has no impact on the natural history of the disease, but will induce cognitive decline. Great! So we have to irradiate earlier. Everyone knows this paper, recent paper, pseudo-randomized. With just biopsy, median survival 6 to 7 years. It's not my view. It was true also by the Van den Bent Lancet publication about early radiotherapy versus delayed radiotherapy, median survival 7 years. And nonetheless, I'm sure that in 2 weeks, finally, I will come back to Montpellier and I will start to meet patients, and they will come with a stable tumor by telling, oh, wait and see, because you know, don't worry. They told me that it's a benign tumor. Everyone knows that now. So we have to change radically our discourse. Yes, but finally, I talk a lot. But did we change something? Median survival in the prospective surgical series, more than 15 years. So it's easy when a patient is coming. Do you want to live with hemiplegia or aphasia 6 to 7 years, or do you want to have a normal life more than 15 years? My patients are strange. They are telling, I would prefer to be upright in order to live longer and better. Oh, really? You understand that we can change radically the natural history of the disease. It's about more than 1,000 cases in the French low-grade glioma consortium. My own series, prospective series, not randomized because it's unethical, prospectively collected. You can see the median survival, 16 years, never published in the literature. With 25% of patients still alive with more than 20 years of follow-up. It does not mean that all other patients died. It means that I'm not so old and I need to continue to follow them, and I hope that we will give more than one generation, because one generation is done. So the question will be again, yes, but how is it possible? Because we cannot remove all the brain if we want to preserve the quality of life. Reoperation. Third surgery. Now I'm doing more and more third surgery. In this period, with 10 to 15 years of follow-up. And each time, you reduce the volume. You prevent malignant transformation. In the meantime, the patient continues to enjoy normal life. You're in agreement with the willingness of the patient, Hippocrates, yourself, the neuroscience, and medical issues. So finally, the dilemma is totally solved. You can do that also in glioblastoma. You tell me, and speaking a lot about low-grade glioma, but you know that if you remove more tumor, it's better. It has been demonstrated by Stummer with a prospective randomized study. It has been confirmed by Mitchberger with 500 consecutive patients, and finally with a recent review 3 years ago in JAMA Oncology, with definitely we have to remove as much as we can. But you will see later that finally I proposed 7-8 years ago, to be honest, I do not remember exactly, to do a supratotal resection also in glioblastoma, and I will show you that never I published my experiencing glioblastoma because they are living 3 years. So we are not waiting 2 months, but 2 years. Why I did not publish these results? Because I select patients in order to be helpful. And then I know that today we have not to select patients, we have to randomize with a computer in Stockholm deciding for me and for the patient in front of me if we have to operate or not. And this is evidence-based medicine. Yes, no. I try to be in agreement with old guys, maybe you do not remember the name, Hippocrates, to select the good indication to the good patients. And suddenly, you change radically natural history of the disease. So that means that sometimes in a butterfly glioblastoma in old patients with cardiac illness and so on, I will say, I have a regret to tell you that I have not to operate because it's not a good indication in your case, despite the guidelines published in New England. So, we change radically both the quality of life, I will show you now, and the overall survival, more than twice now. How is it still possible in low-grade glioma to do a biopsy? And nonetheless, half of patients I can meet in Montpellier, so coming from different countries, blah, blah, you understood, they have no volumetric assessment, they have no cognitive assessment, but they have a biopsy in more than 50% of cases. Why? To demonstrate that it was a low-grade glioma. Really, I think it was a stroke. That's crazy. You do a second MRI and you know what it is. Otherwise, we have to change our job. So, do not perform biopsy. It's forbidden, in my experience, except in some cases of gliomatosis when the brain is totally invaded and this is another disease. So in fact, the vast majority of patients, even today, are not operated on because we're afraid to induce permanent deficit and never we really recognize. It's a young lady, she has just 1 seizure, she's enjoying normal life. I will never take the risk to remove Broca's-Era, the Wernicke's-Era, the left insula, because in fact I know that she has a very high level, high risk to have a permanent deficit. Not at all. She has less than 0.5% of risk. If you do nothing, you will have 100% of risk to see this tumor growing and becoming malignant and killing her. And at that time, it will be too late. Everyone knows that. We have numbers. It's not done because in the vast majority of cases, the tumors are located within so-called eloquent areas. What means? I will demonstrate in the second talk that in fact eloquent areas does not exist. We have to think about not areas anymore, but networks. And suddenly the brain will help you in order to compensate what we cannot achieve by ourselves, the restoration of the meta-networking brain. In other words, we have to burn localizationism. If you continue to believe on Broca's-Era or Wernicke's-Era, please don't operate the brain. It never worked like this, never. And I'm not the first to say that. Pierre-Marie said that 1 century ago. But it was not politically correct because the guy who was finally helping brokers decided that there were some areas dedicated to some specific functions. And neurologists love this concept, while in fact it's totally untrue. And in the field of neuroscience, everyone knows that, the connectivity of the brain, but not in neurology, and not at all in neurosurgery. So you will tell me we can use DTI and fMRI. Yes, I will demonstrate in another talk that, of course, this is a beautiful tool in order to understand brain processing. I am PhD in cognitive neuroscience and functional neuroimaging, so I can tell you that at the individual scale, it does not work. You cannot make a decision to operate or not based on DTI and fMRI. You can if you want, but you will be probably or not so efficient by removing just a part of the tumor, while it would have been possible to do a supratotal resection, or you will induce a permanent deficit and you will say, finally, you see, it's not a good idea to operate too early. Of course, because this is just statistics. So have we the truth in front of us? Yes. Just to wake the patient. Because now we are speaking. We are trying to understand. We are communicating. We are doing social cognition. We are doing many things all together. And maybe you think about something else. Multitasking. If it's true for you, it's true for your patients. How do you want to use just statistics in order to know exactly how these networks are processing at the individual level at that time, knowing that I will show you that over years the brain of a patient will change its organization related to the growth and the migration of the tumor, or related to the fact that you did a first or a second surgery, or related to a radiotherapy. Everything is dynamic. But it's uncomfortable to think that. What we would like is to think that we have Broca's area connected to Wernicke's area, just a tumor mass, and you can remove the tumor mass and join your navigation. No. We have to adapt the tasks according to each patient. We can do more or less what we want into the operating theater. Movement, language, cognition, emotion, behavior. So we have just the choice now. Have we the choice? No. The patient has the choice. So we have to tell that to the patient. In all cases, what do you want? How do you want to define quality of life? Of course, I don't want to be hemiplegic aphasic. Okay, we have understood I did not induce any permanent aphasia, hemiplegia for more than 10 years. The problem is solved. But it does not mean that my patients are human beings after a very extensive lobectomy, because they can change their personality. They can have problems of executive functions, to do multi-tasks, to be very good both at home and during their work. We don't care, the patient is alive. Okay, you have not to decide. You have to explain that to the patient before surgery, and then he will decide in agreement with the informed consent. Informed consent for me is not to have the signature of a patient after 5 minutes. It's to explain everything. And in fine will tell me, and speaking different languages, you have to map 3 languages in my case, which is not true for the next patient. So we adapt. And we have to do this mapping, definitely not at the level of the cortex. And in 90% of department of neurosurgery went, what they did to put grids or to map the cortex and to say, now we can put the patient under general anesthesia because now we know where you are. No, not at all. The risk is in the death. The limitation of neuroplasticity is the connectivity. If you cut just 3 more millimeters of the inferior frontal occipital fascicle, for instance, you will disconnect 2/3 of the hemisphere. We have to be aware about that, otherwise we cannot touch the brain of the patient. So the goal is not to debulk a tumor from inside. It's not an adenoma. The goal is to remove a part of the brain as much as you can, to do a lobectomy or lobectomies sometimes in frontotemporal insular tumor, which are not so rare, according to the functional boundaries, cortically and subcortically, of this patient at that time, as much as you can. And to do that, your navigation, intraoperative MRI, robot, electrocorticography, microscope will never help you. It's just a kind of compensation because we don't know. But if you start to understand the brain, to deal with it online, suddenly you can remove everything and everything becomes an evidence. You know where you are and you can navigate using your own navigator, your 3D representation in your own mind, and of course with the feedback provided by the patient online throughout the resection, the patient will continue to do the neurocognitive assessment. And I'm sure, and if you can remove 130% of the tumor, it will be better because you will see that in case of supratotal resection, suddenly the rate of death is 0. You will tell me, yes, but according to so many tasks and so on, okay, the patient is a boss, he would like to enjoy more life, but you will leave more tumor. No, because I will come back. Before malignant transformation, And it will be possible to remove more because in the meantime the brain will remap. You can see in this case, for instance, that the activation was not the same before the first surgery and after, before the second surgery. And according to that, it has been possible to remove the second time the club of the hand. What means the club of the hand? It depends on each patient, and the same patients over time. Then you remove more tumor each time, and you continue to preserve the quality of life. So first of all, the results, because we can make beautiful talks, but what about truth? Prospective collection of data, almost 800 low-grade glioma within so-called eloquent areas, the Broca's area, the Wernicke's area behind the Labbé vein, the Hollandic system, the parietal system, the paralimbic system, the corpus callosum, you know, everything. No, we cannot operate, it's too dangerous, blah, blah. Rate of mortality, 0. I cannot lie. 90% of my patients are coming from abroad. And you know, neurosurgeons, if you kill their patients, they will kill you. So my patients are still alive. 0.5% of severe permanent deficit when I was younger because I pushed too much at the level of the anterior perforating substance, and we will have a specific talk about that if you want to speak a little bit more about the technical issues. And now I will leave, of course, the anterior perforating substance in order to avoid to have deep stroke. So nothing magic, and what I will expose. How I do it is just to preserve vascularization. This is the main point. You can remove a big part of the brain in a patient with a brain tumor. Otherwise, you don't do that just for fun, of course. With a preoperative cognitive assessment demonstrating that, in fact, the patient is not so well, and then to do post-operative cognitive rehabilitation and to see, thanks to mechanisms of neuroplasticity you pushed, by preserving the connectivity and thanks to this rehabilitation, an improvement of the quality of life related to an improvement of the cognition. Now, before, you cannot remove Broca's area in a patient enjoying normal life and the patient is better 6 months later. Yes, it's possible. It's not possible in a localizationist view of brain processing. You see, I have some difficulties to say the word localizationism. I cannot, because the brain is not processing like this. Except if you cut the connectivity and suddenly you will cut the cable and you will not have imaging anymore. Just for 3 more millimeters in the depth, the danger is in the depth. Plus, of course, 80% of positive impact on epilepsy. I say, of course, because this is in agreement with the rest of the literature. But what we have shown, we published that a few years in Brain with Joanne Palu on behalf of the French low-grade glioma consortium. Epilepsy is related to the periphery of the tumor, the infiltration. So in fact, we continue to have cross relationships, very strong relationships between the microscopy and the macroscopy. So that means that if you debulk the tumor from inside, you will continue most of the time to have epilepsy. If you remove more around, you will improve the quality of life. And of course, you will have more impact on the natural history of the disease. So please remove more, according, of course, to the functional boundaries. At that time, you will tell me, yes, but awake surgery, you have a risk once again and once again, because I heard that thousands times in my life, to leave more tumor. No, each time, good neurosurgeons did classical surgery for low-grade glioma in so-called eloquent areas under general anesthesia. You can see a typical example with the guy who decided to do under general anesthesia a stimulation mapping, so of movement, and then he identified the central sulcus, he did the subpial dissection, and finally he left the posterior part by telling, I don't want to induce any permanent deficit, especially no hemiplegia. And then he stopped. No. If the patient is awake, you can, if the patient is not hemiplegic before, this is a preventive surgery, of course, suddenly you can remove more. Each time I did a second surgery, within the 3 months following the first surgery, performed classically in another department, in all cases, 100% cases, I removed more by doing these tasks. So the dilemma is solved. It's even, to my opinion, unethical to continue to do this kind of surgery. because we can remove more by preserving the quality of life. Once again, median survival, and now this is another sub-series with also 16 years with my colleague Luc Taillandier, neuro-oncologist in another department, and we have some patients altogether on my own series, about 800, so we have 300 cases altogether, so you see that of course I am not sold because I would speak about chemotherapy and when to do radiotherapy and so on, but it's a big process and not just, okay, this is this diagnosis, we will do stop. No, it does not work like this. It's a chronic disease, we have to adapt individually. You will tell me at that time, your results are better because you selected the patients with the good molecular pattern. The answer is no. Even in wild type, you continue to have an impact in 80% of them. Even in 1p90q non-codelated, you can increase more the extent of lesion and to have more impact due to surgery itself. And it's not just my view. Jacola reported exactly the same thing in Annals of Oncology, by telling we can adjust according to the molecular pattern, and finally surgery changed radically in all cases the natural history, the median survival. You can tell me it's possible to do that in Montpellier, in San Francisco and so on, but in the rest of the world it's not. Of course it is. This is the reason why I'm here, because we reported also, thanks to Mitch, in this meta-analysis, probably published in Journal of Clinical Oncology, the meta-analysis of the literature about now 8,000 cases, and if you do mapping, if you don't do mapping, suddenly everything changes everywhere in the world. If you do mapping, your patients are better, and you remove more tumor, whatever the location of the tumor, including in so-called eloquent areas. So the dilemma is solved also. You have judged a choice. Do you want to improve the results or not? But it's true everywhere in the world. And you can do that with a fork and a knife. You don't need billions of euros to buy the Brain suite. So what about the supratotalization? Why supratotalization? Because everyone knows that there are tumoral cells beyond what we can see on the MRI, which is just macroscopy. Because when I compared my series with supratotalization according to functional boundaries, of course, so I pushed each time it was possible to just the totalization. Suddenly, in the subgroup, no malignant transformation. So, of course, all patients still alive. With just chemotherapy in one case, no radiotherapy, never. Because I will demonstrate to you, it's not my series, but in the new literature that radiotherapy is burning the connectivity, which is just an evidence. So, we are not speaking about glioblastoma patients who will die within the next 2 years. We are speaking about patients who will die maybe after 20 years. So they have to preserve their high cognitive functions, including metacognition. What do you want to plan for your next 10 to 20 years? It's complex without brain tumor. So you can imagine with a brain tumor. So we need to preserve our metacognition, knowledge of knowledge. I will speak about that. So you will tell me you have not enough follow-up. Of course I have, more than 10 years. And what happened in the subgroup of patients with supratotalization? No death. But I have not cured them. I started after 10 years to see flare occurring around a beautiful cavity initially. So I know I did not cure them. It's a chronic disease. I have to continue to follow them, to do an MRI every 6 months, and I will finish to reoperate. Or at that time, we will finish to irradiate. So please keep this ACE at the good time. Think about the next follow-up, and not just what will occur in the next 5 years. 5 years is nothing like glioma. If we have foci of malignant transformation, you can do exactly the same thing. To remove more according to the functional boundaries, both at cortical and subcortical level, and then finally to do only chemotherapy if it's really high-grade glioma without radiotherapy too early, to preserve the quality of life. You kill the patient before the tumor will come back. No, not so rapidly. And I have the proof about hundreds of patients. You can do that even in very big tumor with a big enhancement, with a big mass effect, and so on, only PCV in this case, etc., etc. We can do that in this kind of very also extensive tumor pushing the brain, glioblastoma, and I have in this patient 16 years of follow-up.
Tengo en estos pacientes 16 años de
glioblastoma,
el glioblastoma,
3 years of median survival, with many patients with good selections, of course, 10 years off. It was not a glioblastoma, blah, blah, okay, we can discuss with neuropathologist, they examine again the sample, so 10 times by 10, oh, finally, maybe it's really a glioblastoma. Yes, because, of course, we turn around the flare. I do not speak about the enhancement anymore. We are beyond the enhancement. In fact, we didn't care the enhancement. Everyone knows that the problem is the flare. And finally, after proposing this supratutorization in glioblastoma, because we know that we can increase the median survival, then I have seen Raymond Sawaya just 3 days ago, so the ex-chairman of the MD Anderson, because now he retired, he gave his last talk. And finally, as you know, they published in MD Anderson, if we remove more than 50% of the flare, then we increase the median survival. Really, more you remove tumor, more you will increase the survival. What a scoop in oncology. How to explain that to surgeons? We can make the difference and not against the quality of life. But of course, if we can arrive earlier and earlier and not just when the tumor exploded, in glioblastoma, blah, blah. So it's better also to change radically the long-term follow-up and maybe to cure some patients. So this is the reason why I started many years ago to operate incidental low-grade glioma before any symptoms. And many guys say, oh, it's criminal, you know, it's a benign tumor, the tumor is stable, the patients are well, blah, blah. Okay. First of all, if you do just MRIs longitudinally, and I had so many, of course, witnesses, control patients in another groups. What happened? Strange, the tumor grew in all cases. Oh, it's not stable. Now it's a tumor, even if the patient has no seizures. Incidental discovery. Are you sure that there weren't? So we did the neuropsychological examination in patients with incidental discovery of low-grade glioma. In 60% of cases, they had deficit already. They are not well. We would like to believe on the fact that they are well because it's more comfortable for us. But this is not the truth. Third, yes, but before you will not operate that in the insula, you take a risk, incidental discovery, this tumor will never become suddenly malignant in a patient without any symptoms. Wrong! This tumor became suddenly a glioblastoma in a patient with a normal life, and suddenly they decided to refer the patient to me, too late, because of course I did surgery, it was a glioblastoma, and the patient was able to live 3 years. More, but finally, for nothing. It was a glioblastoma. At that time, everyone would like to operate. Why? It would have been possible for me to do supratutorization with 99.5% of good results and to avoid that. But how can you say that you will avoid that? Because in my subgroup or supratutorization, the rate of malignant transformation is 0 with more than 10 years of follow-up, 14 in fact now. So I know that I would have been able to avoid this malignant transformation. But at that time, everyone can do surgery, even in so-called dangerous area, because we have nothing to lose. Of course, we have nothing to win. 3 years is beautiful. 20 years is better. So my series with the first 100 patients with incidental discovery of low-grade glioma, which are not benign.
de bajo
In
grado que no
this
era benigno.
subseries,
En esta subserie
30% of supratotarization. Of
se
course, the tumor
hizo
are smaller,
resección
so you increase the
supratotal, por
chance
supuesto, el
to
tumor era
remove
más
more
pequeño
and to
y se
take a margin
aumenta
around.
más
So
la posibilidad de
the rate
remover
of
más.
death is, of course,
La
zero,
tasa de esto
and
de
the
muerte
rate
es
of
cero,
patients enjoying
y la
normal
tasa
life
de
is,
pacientes
we
con
will
vida
publish that
normal.
in your surgery next
Esto
month.
lo publicamos en Neurosurgery.
98% of cases
Este,
still working.
98%
Will tell me,
de los
you
casos
see,
aún
you had a
están
problem.
trabajando.
Yes,
Me dicen, tenía un
an
problema.
airline
Sí.
pilot is
Por
perfect.
ejemplo, un piloto
Your
de
condition
aerolínea
perfect.
está
No
perfecto,
seizures.
está
No
perfecto,
adjuvant
vuelve a
treatment.
trabajar,
But
no ha
for
vuelto a tener
medical,
ataques.
legal
Por
issues
lo
and
tanto, los
insurance,
temas
it's not
médicos,
able to
legales y
pilot
financieros,
Boeing
pero,
actually.
pues realmente ya no puede
So it's not
pilotear.
a medical problem.
Entonces
It's
no
a
es un problema
societal
médico,
problem.
es un problema social.
Otherwise,
De lo
all
contrario,
patients return to a
todos los
perfect normal
pacientes
life working full
retornan a su
time.
vida normal, perfecta, trabajando tiempo completo.
So we decided,
Entonces
this may be
decidimos,
crazy, but you remember probably
pero
that
tal vez
Pat Kelly
probablemente
proposed that
ustedes
in New York
recuerden
15 years
que
ago,
el doctor
to propose a
propuso
screening
en
in
Nueva
the
York
general
que hace 15
population.
años
And
propuso
with
este
the reasons
tamizaje
I
en la
have shown
población
you,
general, y una
I
de las
went
razones
2 years
que les voy a
ago with
mostrar
my
hace unos
colleague,
años
young
con mi
oncologist Luc
colega
Taillandier,
oncólogo
in front of the French
Taillandier
Academy
en
of
la Academia
Medicine, and we
Francesa de
proposed to do a
Medicina,
screening at
fuimos
least
y
between
propusimos
20 to 40
hacer
years
este
in the
tamizaje
general population today
de
in
20 a
order
40
to
años en la
identify
población
earlier
general hoy en día
smaller
para
tumor
identificar
and
más temprano
to
este
start
tipo
also
de
to
tumor y
better understand the
tener
genesis
mejor
of this kind of tumor, because
una
most
mejor
of the time
comprensión
we
de la
arrive too
del
late.
origen de este
Now
tumor,
you can do
porque
also
ahora
very
podemos-
extensive
porque si no vamos a
molecular
operar muy tarde, ahora podemos hacer
examination and to
exámenes
try
o
to
tener,
better understand the origin.
el origen,
The National
entender el
Academy said
origen.
yes,
La Academia
and we
Nacional
have asked
dijo sí,
to
y pedimos
subgroup of
Pero,
the population,
y pedimos un subgrupo de
66%
población,
of them
66
in a
personas de
survey
ellos
said,
en una
why not?
encuesta dijeron,
I would
¿por qué
prefer
no?
to know. And
Yo
more I'm
preferiría
doing
saber.
that,
Y
especially
al
in the
hacer más y
family
más esto,
of patients
especialmente
who
con una
died
familia de
from
pacientes o
glioma.
con la historia familiar
And
de
they are coming
pacientes
spontaneously.
en las
I
que
will
han
show you
muerto
some
con
examples by
glioma.
telling,
Entonces,
I am
tenemos
young
algunos
and I would
ejemplos
like
de
to know if I
pacientes
have a
que,
tumor.
bueno,
The last
yo
one
soy
was
joven y quiero
before to get
saber
various.
si tengo un tumor.
We did an MRI, we
le
found the
hicimos un
tumor,
MRI,
I removed
encontramos
the
el
tumor.
tumor y
With a
removí el
supratorization, the patient
con
is
una
better in
suprarresección,
comparison with the
y el paciente
preoperative
está
cognitive
mejor
assessment, which was
en
normal,
comparación con
but
la
because in fact we pushed too
preoperatoria,
much the brain
que era normal.
in order to
Entonces, presionamos
increase
el
the
cerebro
plastic potential.
para
Even in
incrementar el
normal
potencial
scores
plástico.
before surgery,
Incluso en
you
el
can
curso
do an
normal
extensive
antes de la
resection
cirugía,
and to
se
have
puede
better
hacer una
scores
resección y
3 to
tener
6
mejores
months later.
puntajes
You
3
know
a 6
why?
meses
Because
después.
human
¿Saben
being
por qué?
is not
Porque el
thinking
ser
enough.
humano no es algo estático.
So according to that, of course,
Entonces,
the most
según eso,
complex
por
part,
supuesto, la
when
parte
to do
más
adjuvant
compleja,
treatment.
¿cuándo hacer ese
It depends
tratamiento?
if the surgeon
Depende
removed the tumor
si
or
el
not,
cirujano
even if we
remueve
know
el
that we
tumor o
did
no.
not cure the
Incluso
patient
si sabemos que
because
no curamos
it's a
al
chronic
paciente
disease.
porque es una enfermedad
And you know,
crónica.
everyone, of course, this
Y
paper
claro,
by telling, we decided that
Conocemos este
40 years
artículo de
is the
decidimos
limit.
que
If
40
you have
años
more
es
than
el
40,
límite, y si
you
tiene
should
más
be
de 40,
irradiated with
debe ser
PCV.
irradiado.
My problem is that my
Pero
patients are
mi
living too
problema es que
long.
mis pacientes es que
So
viven
when I
demasiado.
started to operate them
Entonces, cuando
around
empecé a
30,
operarlos
when I do the
alrededor
second
de los
surgery
30
and the
años, cuando
third
hice la
surgery
segunda
15
cirugía y
years
la
later,
tercera
they have
cirugía
more than 40.
15 años después,
So
ya tenían más de
suddenly,
40
even
años,
if the
entonces, de
molecular
repente,
biologist and the
incluso los
neuropathologist are telling me it's
biólogos
really
moleculares y los
low-grade
patólogos
glioma,
dicen,
you
bueno,
did
van a
that
operar,
preventively.
esto lo hizo
According
preventivamente,
to
pero
the beautiful
según
evidence-based medicine, we have to
la
burn and brain.
medicina
Do you think that
basada en
it's
evidencia,
reasonable? Of course,
no
I'm
podríamos operar
totally
ese
honest
cerebro,
with the patient.
pero
By
he
telling
sido
now you have the
totalmente
choice,
honesto con el
according
paciente,
to
decirle, bueno,
evidence-based
ahora tiene
medicine, we have to
la
do
oportunidad,
radiotherapy and
según la
chemotherapy, and the
evidencia,
patient
tenemos
is
que hacer
saying, why?
radioterapia y quimioterapia.
You
Y el
told me
paciente va
that
a
you
decir,
did the
¿por
first
qué?
surgery
Usted
just
me dijo que hizo
preventively.
la
You
primera
told me that
cirugía
in your pathological
preventivamente.
examination
Me
is
dijo
not
que
in
la
favor of
evaluación
malignant transformation.
patológica no
I'm
estaba a
well.
favor de la
3 months following
transformación
surgery,
maligna,
thanks
y
to
después 3
the
meses
third cognitive
después,
rehabilitation, I would
después
like
de
to
esa
enjoy normal life.
rehabilitación, yo
Why do you
quiero
want to
tener una vida
irradiate
normal.
me?
¿Por
I
qué me
don't
quiero
know.
irradiar? Yo no
Just
quiero
recommendation. I have to apply the
simplemente por
law,
una
you know.
recomendación, tengo que
And patients are
aplicarla,
telling me in
¿no? Y los
99%
pacientes me
cases,
dicen, en 99% de los casos me dicen, no,
it's my decision.
es
Of
mi
course, I
decisión.
agree.
Por supuesto.
And then I have a phone call of the oncologist.
Ahora recibe una
You
llamada
cannot
de un
imagine,
oncólogo.
it's
No
terrible.
se puede
I have seen
imaginar,
the
eso es
patient,
terrible,
he
tengo
doesn't
este
want to be
paciente
irradiated,
y no
he's
quiere
totally
ser
crazy,
irradiado, está totalmente
but he's living for
loco,
15 years.
pero está viviendo más de 15 años.
You see, sometimes problem of
Entonces,
evidence-based
a
medicine.
veces ese es el problema con la medicina basada en evidencia.
But in this beautiful article,
Es hermoso. Este es
no
algo
objective
hermoso.
evaluation of extemporization. The
evaluación
surgeon
objetiva
said, I think that.
de la
I
resección
love surgeon
máxima
telling, I
objetiva.
believe.
Es decir, yo soy un cirujano y yo creo en
Very
eso.
good to be published in New England, I think. You see, very rigorous.
Es una revista
No
muy
armed with
rigurosa.
chemotherapy alone. What
No-
about if we
no se
did
hace con-
only
solamente con
temozolomide?
quimioterapia.
Yes, but radiotherapy
Pero
should be the gold
entonces, la
standard.
radioterapia debe ser
Yes,
la
but
regla de
Van
oro.
den Bent demonstrated
Bueno,
using
pero se ha
evidence-based medicine
demostrado
that early
con
radiotherapy did
medicina basada
not
en
provide
evidencia que la
more
radioterapia no ofrece
longer
más,
survival rather
sobrevida
than delayed radiotherapy.
que
Yes,
la
yes, but we have to
radioterapia
irradiate.
tardía.
In
Sí,
all
sí, pero
cases
hay que
because we
irradiar.
decided.
Pero en
Who
algunos
decided?
casos porque decidimos, pero ¿quién decide? ¿Quién
No
decidió?
cognitive assessment.
No se
The most
tiene
important part.
valoración
No, no,
cognitiva,
we
es la
did
parte más
extensive
más
assessment.
importante. Pero hicimos el
Minimal
MMSE.
mental status. Yes, it's for
estatus,
just people with
mental.
dementia.
Es
I'm
simplemente
speaking
para
about
personas con
normal
demencia,
people
pero estamos hablando de
enjoying their
personas
own life.
normales
And
que
just 5 years.
llevan una vida normal y
This
solamente
is not a
5 años.
high-grade glioma.
Pero este
We
no
are
es un
speaking
glioma
about
de
patients
alto
living
grado,
more
hablamos de
than
pacientes que
15
viven
years.
más de 15 años.
So we have
Entonces tenemos
to see what will happen with
tenemos
the
que ver
longer
qué va a ocurrir
term follow-up, because you know
a
that
largo plazo
radiotherapy
con
will
ellos,
induce
porque sabemos
cognitive
que la
disorders
radioterapia va a inducir desórdenes
5 years
cognitivos
later, most of the
5
time.
años después, en su
Yes, but
mayoría.
we know
Sí,
that, but
pero
we are not able
sabemos
to do this kind of
que
studies.
no
So
podemos
why you
hacer
publish
ese
in
tipo
New
de
England that
estudios.
it should be the
Entonces,
Bible?
¿por qué publica en New England que debe ser viable?
This is the Bible. Evidence-based medicine.
Esta es evidencia.
Lancet. Early
En Lancet.
radiotherapy, no early radiotherapy. Median
Con
survival. It's
radioterapia
not my
y
imagination.
radioterapia tardía.
So the conclusion
Y la
is we have to
sobrevida
irradiate
no es,
earlier.
No es mi
I have not
imaginación, la
understood.
conclusión es que hay que irradiar
Please,
más
can you
temprano.
explain?
No entiendo eso, ¿por qué? ¿Me lo pueden explicar?
Recently, it's not my
Recientemente,
series.
y esta no
From
es mi
US,
serie, esta es una
1,000
serie de
people.
los Estados Unidos.
We don't care, it's not
Ni
randomized.
persona,
Yes,
no es
but 1,000.
aleatorizado. Bueno,
No
pero tiene 1000
longer
pacientes.
long-term overall
No
survivals,
hay
different
sobrevida
symptoms
más
in
la-
patients with
más
high,
larga en pacientes
high risk, grade 2 glioma treated with
con
chemotherapy
riesgo-
versus
con riesgo
chemoradiotherapy.
alto, con gliomas
So, of
de
course,
grado
because there
2
is no
tratado
difference,
con
we have to irradiate.
RCA comparado
Because
con
this
RCA.
is the
¿Por qué?
law.
Porque habría que irradiar, porque eso es lo
Another
que dice la
series
norma.
with
En otra
2,000
serie con 2000
people.
con
Yes, but
2000
we don't care,
personas.
it's not
Sí,
randomized. So
pero no
we can
nos
say
importa porque no es
2
randomizado.
billions.
Pero es,
We
uno
don't
podría
care,
decir, es
especially because the
conveniente
results suggest that chemotherapy alone was independently
sí, pero
associated with longer
que la
overall
quimioterapia
survival
sola
when compared with
estaba
radiotherapy
asociada
alone.
con la sobrevida
Yes, but
comparada
this
con
is
la
not the-
radioterapia sola.
the law.
Pero bueno, esa no es la norma, esa no es la regla.
Maybe sometimes
Sí,
we
tal
have
vez a
to
veces
fight
tenemos
against the
que
law if it's
jugar un
for
poco
our
en contra de
patients.
las reglas. Si
You
es
remember
a favor de
Hippocrates?
nuestros pacientes. ¿Recuerdan a Hipócrates? ¿Sí?
Early radiotherapy
Entonces,
induces
la
progressive
radioterapia
cognitive decline.
temprana
It's not from me. Lancet Oncology.
induce
Long-term
declinación
survival,
cognitiva
long-term,
progresiva. Eso no
not
viene de
just
mí,
5
eso viene de
years.
otros
Our
estudios.
patients are
No
living
solo a largo
longer.
plazo, nuestros
Who
pacientes
did not
viven
have
mucho más.
radiotherapy at
No tuvimos
stable
radioterapia
radiological and cognitive status.
y no
By
afectado
contrast,
el
patients with
estatus
low-grade glioma
cognitivo.
who receive
En
radiotherapy
contraste,
showed a
aquellos
progressive
pacientes que
decline
reciben
in
radioterapia
attentional
mostraron
functioning
una
and so on
declinación
and so on,
progresiva en el
even when they were
funcionamiento de la atención,
irradiated
incluso
in the
cuando
state of the
recibieron,
art.
según
We don't
el
care.
estado del arte.
The law is to irradiate.
Entonces, la norma es radiar.
I gave this
¿sí?
kind of
Incluso
talk
hay.
in front
Ahora,
of
de nuevo, ese tipo de
100, 200
frases.
radiotherapists in Miami 1 year ago. I'm still alive.
y mis
So that means
pacientes
that
aún están
they
vivos.
understood.
Eso significa que
Maybe
debemos entender que
that
tal vez
They have a problem.
se
They don't know
tiene-
how the brain is processing.
se tiene
So
un
that means
traductor.
that if you do
Eso
an extensive
significa
resection according to
que
functional
necesita
boundaries, what
una
you need
sensibilización
is
según
the
las
connectivity,
fronteras
the minimal
funcionales. Eso
common brain.
significa
Then if you damage
conectividad,
it,
el
you will
cerebro
induce
mínimo común.
cognitive disorders. It's true for
Y esto
neurosurgeons,
es cierto
it's true
para
for the
los
radiotherapists.
neurocirujanos y para el radioterapista.
Example, it's not from
Por
me.
ejemplo, esto no proviene de mí.
18 months after radiotherapy,
18 meses
increased
después de
radial
radioterapia,
diffusion
incrementa difusión radial.
significantly predicts decline in verbal
Significativamente
fluency.
predice una
In
declinación
other
en la
words,
fluidez
you
verbal.
irradiate the
En
patient,
otras
but you are
palabras,
totally honest
irradian a un
by doing
paciente,
pre- and post-radiotherapy
pero
when you
al hacer pre- y
have
post-
cognitive
radioterapia,
assessment and not just a
hacen una
MMS.
valoración cognitiva y no solamente el MMS.
you do
y eso
DTI.
y hacen
Why?
DTI.
Why matter
¿Por
tract?
qué?
What happened? You have a
Lo que va a
decline
ocurrir es
of
que
the
va a tener
cognition
una
and
declinación
DTI
en la
show
cognición y el
problem
DTI va a
of
mostrar un problema
myelinization.
de
Just an
mielinización.
evidence. You want
Simplemente
other
la evidencia.
examples? I will not spend the day to show you so many papers. Radiation-induced brain injury. It's not just Hugues Duffau thinks that. This is the truth. And we don't want to see the truth. Nobody fit on overall survival, decline of cognitive function. Strange, no? And we will continue to apply New England, because this is the New England. Have you an alternative? Because sometimes you cannot reoperate because we reached the limitation of neuroplasticity. Yes, chemotherapy. Because chemotherapy will not induce any damage of the cognition. With 10 years of follow-up, we demonstrated that. And you will tell me, you think that you will see a shrinkage under temozolomide in low-grade glioma? My answer is yes, because you can see by yourself. And then when you have a shrinkage, especially at the level of the connectivity, especially in the contralateral hemisphere, which is the limitation of neuroplasticity, then you can reoperate. That means that it will open the door to another surgery. Then to decrease the volume again and to avoid malignant transformation while preserving the quality of life of the patient. Example? Who would like to operate this patient? 10 seizures a day despite 3 antiepileptic drugs. I did first surgery. We gave temozolomide, my colleague Victor Young. I did a second surgery thanks to a shrinkage. You can see the results now. No seizures anymore. Driving, working full time. We increased the quality of life. And you will tell me, of course, you selected patients with 1p92 co-deletion. No, it is not 1p92 co-deleted, which is true in 50% of cases. So if you apply this protocol based on molecular pattern at the individual level, you do not your job as a medical doctor at the individual level. So chemotherapy is the first post-surgical option. Radiotherapy should be postponed. We say Duffau is saying that. No, Monica Higues, on behalf of the INO consortium, regardless of the 1p92 status, I did not change one word, to defer radiotherapy for long-term preservation of cognitive function and quality of life. Oh, really? So we have not to burn the brain? No one would like to apply that, because it's politically incorrect. But this is what we have to do. This is the reason why we reported in your oncology with my colleague Luc Taillandier and more recently Emmanuel Bondonnet what we have to do in front of low-grade glioma patients. Of course, remove the tumor as much as you can according to functional boundary. Do a rehabilitation, and it will be now the second talk about the plasticity of the brain. And then you will come back because of remapping. And then you will come back again, and each time you will reduce the volume before malignant transformation. And the patient will continue to enjoy normal life, 5 years, 10 years, 15 years. And at that time you will say, no, I cannot reoperate because of migration within the white matter tracts, the limitation of neuroplasticity. And what you will do, chemotherapy, independently of the molecular pattern. Then you will have at least a stabilization in 90% cases, shrinkage in 1/3, eventually you can reoperate, and finally we will irradiate. For radiotherapists, don't worry, you will have your job. You will have to irradiate because we cannot cure that. But after 10 to 15 years in my experience, then if we have decline of cognitive function between 15 to 20 years, that means that they enjoy a perfect normal life during 15 years. And finally, 20 years of follow-up, one generation, allowing them to think about long-term projects like to have a baby, to buy a house, to increase, if you want, in your job, and so on and so on. So, surgeons, but also radiotherapists, but also medical oncologists, because sometimes they can really induce this shrinkage, should know this atlas we published in Brain 3 years ago about the limitations of neuroplasticity. It's an MNI template. You can use it if you want before to go to the OR and to have more than 90% of reliability, the prediction of the extent of resection. Because there is no secret. If you cut the arcade fascicle, it will be like if you cut the corticospinal tract, the patient will get terminal deficit. except the fact that we have understood now at the level of regarding higher cognitive functions. So it will be, of course, politically incorrect, but nonetheless we will publish it in neurology, the first journal of neurology, in 1 month. When you have, as I told you, foci of grade 3 or even 4 in the middle of the tumor, and if you did a very extensive resection in secondary high-grade glioma, we postponed in this subseries with 60 cases chemotherapy and overall radiotherapy. The median before giving radiotherapy in this series is 9 years. 9 years. There were 10 glioblastoma. 5 years overall survival, 95% of patients. We can change radically the natural history of the disease. Nonetheless, I'm sure that in your department today, if you have a focus of malignant transformation, especially glioblastoma, your pathologist is telling, oh, it's a glioblastoma, you will do too. Or your oncologist will do too. I will say to them, don't touch to my patient. And they're still alive, and me too, once again. Example? This patient I operated on in 2002. You don't need to be a specialist to understand in your pathology that it was a high-grade glioma. What I did is nothing. Before you're a criminal. But I was a criminal to operate. I was a criminal to operate under local anesthesia. Finally, the patient is well. Now, I am a criminal to do nothing. Please, leave me alone. 15 years later, after my life, the patient came back because I continued to follow her, of course, and I did a second surgery. And at that time, the senior pathologist told me, oh, you removed a low-grade glioma. Oh, strange. It was a high-grade glioma 15 years ago, no chemoradiotherapy in the meantime. You will tell me this is exceptional. No, we will report this series in neurology next month with a glioblastoma, grade 4. You can see it. Supratotal resection, including Broca's-era, blah, blah, you understood. The patient is well, enjoying normal life, no chemo, no radiotherapy, working full time. And don't worry, this tumor will come back, and don't worry, the patient will finish to be irradiated, and so on and so on. But 15 years later, so to conclude this first talk about neuro-oncology, surgery has a significant impact on natural history of diffuse to grade glioma. It is demonstrated. And I said in front of 100 people also in San Francisco a few days ago, a trial with randomization today is unethical. Because once again, you have just to propose to the patient to tell the truth. Do you want to have not 2 years of survival, median, or 16 years. Most of the time, they're selected to be alive longer. Reoperation should be considered more systematically. In a trial, it's never into consideration. And maybe we have to reoperate. No, it's just surgery, yes, no. If it's no, it will be no. Ad vitam aeternam. Why? The brain is processing differently. You know, neuroplasticity, no, we don't know because we are radiating the brain. You're right, after radiation there is no neuroplasticity anymore. Objective assessment of the extent of radiation. You should do the FLAIR volumetric assessment before and after surgery. And of course, you will have also your pathological and molecular data, and it will be a part of the history because I'm doing very extensive lobectomy, and in fact, they love me in this lab because they can do so many research by also seeing the 3D organization of the tumor, explaining why we are doing so many projects about heterogeneity and not just piecemeal by telling, okay, I have seen a focus of a glioblastoma, I will say that it's a glioblastoma. No, you should refer the law. Objective neurocognitive assessment is needed before and after each treatment. Why only surgery? I have shown you some preliminary results after radiotherapy too. No, after radiotherapy the patient is well, it's moving, speaking, is alive, I'm happy. Yes, you're happy, but you have to ask the patient and his family. Quality of life should be the first endpoint. Yes, but it's too complex. It's not complex. No, if the patient is well or not. No.
No se trata de si el paciente
That's
esté
true.
bien o
You
no.
never
Eso
performed
es
any
cierto.
cognitive
Nunca se
assessment, so you
realizó
don't know
una
finally.
evaluación cognitiva,
So
entonces
just
usted no sabe.
Alive,
Entonces
dead
simplemente
is easier,
la vida,
but we are not
muerte es
here
algo
in order
fácil.
to make
Pero
something
aquí no
easier.
estamos
It's
para
complex
hacer
to
las
take
cosas más
care of
fáciles.
patients with
Es
brain
complejo
tumor.
tomar o cuidar pacientes
Take
con
home
un tumor
message if you can
cerebral.
remove
El
more
mensaje
rather
para
than the
llevar a
flare,
casa,
because we have
si
understood
se
that
puede
since
remover
Catherine
más
Dumas-Duport and
si
Pat
se puede
Kelly, that
remover más
of
es
course there
mejor,
are tumor
según
cells
el
beyond what we
flare.
can see on the
Hay
right,
que ir más
despite
allá de lo que
the
podemos ver en el
development of
MRI
imaging. I
por
did
el
also this kind
desarrollo
of talks
y hemos
in
visto
a
ese
society
tipo
of
de
neuroimaging. They are
herramientas
telling
en la
me,
sociedad
I
de
can see a tumor
neuroimaginología. Me
cells,
dicen,
a
puedo ver
tumor
un
cell.
tumor,
No,
un
they
tumor en el
cannot.
sitio.
They
No,
cannot.
ellos no pueden hacerlo. No es así.
The risk of seizure will, in
El
fact,
riesgo de ataque
significantly lower if you remove more,
es
not only
significativamente
tumor,
menor
but
si
also
se
brain
remueve
invaded
más
by
del
the
tumor.
tumor.
Pero
So you
también
will
parte del
increase the
cerebro
quality of
invadido
life
por
because,
el
of course,
tumor.
if you have the seizures, you
Entonces,
can decrease the
se puede
antiepileptic
disminuir,
drugs,
entonces,
and the patient will be
esa
able, for instance,
posibilidad
to
y el
drive. So to
paciente
come
va a
back to
poder
work,
funcionar
while
y
I don't
conducir
know
y
the
volver
law
al
here,
trabajo.
but in
No,
France, if you have
¿por qué?
seizures, you
Pero
cannot
no sé
drive.
las leyes
And
acá,
half of my
pero
patients
en
are
Francia,
telling
si
without
usted sufre un
driving, I
ataque
cannot work.
epiléptico, no puede
But
manejar.
he's
Si no
not
puede
hemiplegic
manejar,
aphasic,
muchos
so
pacientes
we
no
can be
pueden
in
ir a
meetings by
trabajar,
telling my
pero si
patient
no
is
es
well.
hemipléjico y
You sure it's
afásico,
enough?
sí puede asistir, ¿sí? A reuniones y trabajo.
Supratotal resection is more
Pero
frequent in
la
incidental
resección
low-grade glioma.
supratotal
Just
es
common
más,
sense. Arrive
común
earlier, you will remove more,
en el
and you will
tratamiento de
preserve the
gliomas.
quality of
Llegar
life
más
of the patient,
temprano,
because you have
remover
just to
más
preserve,
y
not to
preserva
restore
la
when you
calidad de vida
arrive
del paciente.
later. If the patient starts
si lo
to
hace al
have
llegar más tarde,
movement, cognitive
el paciente
deficit,
tiene
it's just science fiction
déficit
to say,
cognitivo.
I
Puede
will
ser
remove the
ficción
tumor
decir,
and you
voy
will
a
be
remover
better.
el tumor y usted va a estar mejor.
No.
No es así. No.
Surgery is
La
safer,
cirugía es más segura.
and the next step, so,
Y el
is screening.
siguiente
It's not
paso,
so expensive.
el tamizaje no es
We
tan
have published that
costoso.
in cancer
Y
by telling
probablemente
that,
lo hemos
in
hecho
fact,
en
because
cáncer,
our
diciendo,
patients are
porque
working
de hecho
for a
nuestros
long time,
pacientes
they are not
han estado trabajando por
expensive
mucho
for the
tiempo
society.
y esto no es algo costoso para la
So I
sociedad.
will not discuss about the
No voy a hablar entonces sobre
post-operative adjuvant treatment, but just
el
by telling that
tratamiento
it's a
postoperatorio.
more complex
Simplemente voy a
history,
decirle-
and that we
decirles
have
que
finally
tenemos una
to take
historia
care
más
about the
compleja
growth rate. I
y
spoke
tenemos
about that
que
initially, just
ocuparnos
on
de la
evidence,
tasa de
and
crecimiento,
the
como
invasion
decíamos
of
anteriormente, y la
the
invasión
subcortical connectivity limitation
de
of
la
neuroplasticity or
limitación,
not, and
funcional
spatial
o
heterogeneity.
o
So
cognitiva, y
we
la
have proposed to
heterogeneidad
do
de
chemotherapy,
la
whatever
plasticidad.
the molecular pattern, and once
Proponemos
again, in
aplicar
50% of cases, you have a
quimioterapia
shrinkage,
y
even in
seguir el
real
patrón molecular.
astrocytoma, according to the new
Incluso, y lograr
classification, and
estabilización
even
en
in wild
90%
time.
de los pacientes con
The
astrocistoma
actual
según
impact of
la
early
nueva
radiotherapy
clasificación.
per se
Ahora, el
is
impacto
not
real de la
demonstrated. Remember
radioterapia
the
temprana
recent
per se
review
no está
I show you.
demostrado.
I'm not
Según
involved
esa
in this
revisión que
review,
les mostré,
meta-analysis published in
sobre
New
este
Oncological
meta-análisis
Practice with
publicado
Van
en
den Bent and
neuroncología,
Mitchberger. They said finally
queremos ir
that
un poco
early
más
radiotherapy
allá.
had no impact on the
Y eso
survival.
decía que la radioterapia no
Look at
tiene un
radiotherapy
impacto
as a
sobre
risk
la
to
sobrevida.
limit your plasticity.
La
And this is the
radioterapia
reason
tiene un
why
impacto,
everyone
inhibe
involved
la
in brain
neuroplasticidad. Por eso todos
treatment
los que
should
están
know the
involucrados
brain
en el
first,
tratamiento del cerebro deben conocer primero
including
el cerebro,
radiotherapy. So
incluyendo
finally,
a
we
los
concluded this
radioterapistas.
meeting in Miami by
Finalmente
telling, please come to
concluimos esta
Montpellier,
reunión en
and you will
Miami
learn not how to
y
irradiate the
van a
brain.
aprender
I'm not
cómo no
involved in this
irradiar
field,
el
and not
cerebro
to avoid to irradiate,
para
because one day I
evitar
will be very
irradiar,
happy to
porque
keep
un
this
día van a estar
ace,
feliz de
but
mantener
how
esto
to better
y
irradiate
cómo
according to the
irradiar
knowledge
mejor
of the limitation of
según el
neuroplasticity,
conocimiento de la
including this
limitación de
atlas
la
I showed you.
plasticidad, incluyendo esos
So for
casos que
younger
les
people,
mostraba.
be
Entonces,
careful
para
today,
las personas más
because
jóvenes,
you have the
tengan
choice.
cuidado hoy en
So
día
you
porque
have
tienen
to
la
give
opción.
the choice or
Tienen
not.
que dar la
You have
opción
this
o no.
choice to your
Ustedes tienen
patient.
esa opción para darle al
To
paciente.
have a medicine protocol
Tener
driven
un protocolo
treating
de
tumors,
medicina para tratamiento
dogmatic
del
view
tumor,
also of just one
evitar
single brain,
una
Broca's
vista
area,
dogmática de un solo cerebro porque la areólica está
abusive
aquí,
use
bla, bla,
of
bla.
technology, you
El
know, it's
uso
better to have
exagerado de
intraoperative
la
MRI because I
tecnología.
feel comfortable
Claro,
with
por
neural
supuesto, yo
navigation,
me
why I don't know
siento
brain
cómodo con el
processing.
MRI y la neuronavegación,
Statistical
pero si no
reasons,
conozco el
but apply to
procesamiento
the individual
del cerebro.
level. So
Hay que tener en
frequently,
cuenta los
no,
resultados
we
estadísticos de
understood,
los
of course, it's
ensayos
just a trial.
aplicados.
We will
Sí,
keep
pero según
reasonable, and to use these statistics at the individual level. And finally, I went to so many tumor boards in the world, and what is the molecular biology? This is wild type. Okay, we will do it too. But I thought that we had to apply. Yes, but I will understand you later. Medical legal issues, you know, we have no time to discuss. It's better for the patient. We apply the protocol, blah, blah. Okay, I understood. Don't explain to me. The apology of survival independently of the quality of life, except when there are medical doctors, because I'm treating so many medical doctors. Suddenly they think, but you know, what I want first of all is to continue to do my job. But you need empathy. You know, that means mentalizing, social cognition, emotional process, behavior. Yes, yes, of course, of course. But I thought that it was just science. 2 weights, 2 measures. I live that every week. A molecular medicine that finally, I'm sorry about that, it's just a part. Once again, I have a lab of molecular biology, and we are doing a lot of research, especially about malignant transformation and heterogeneity, but in collaboration with clinicians. Because you have the choice, treating a plastic brain and not just a tumor. Understanding the individual dynamic functional organization and reorganization, I will see, opening the door to so many surgeries in patients enjoying normal life. And of course, using this natural history of the disease by understanding the relationships of how the tumor is growing, migrating, transforming or not at that time in this brain, reaching or not the limitation of neuroplasticity. And asking in fine to the patient, what do you want? Because at the end of this kind of talk, they can understand in 99% cases. No, you cannot deliver so many information to a patient, is not involved. Of course, you can. You take your time, you have seen that, and sometimes if we need 2 hours, we will take 2 hours. And in the end, the patient will say, this is exactly what I want. Taking eventually many weeks in order to think about this personalized management. And then we have a big equation to solve over time, explaining why I published this paper about the limitation of evidence-based medicine in neurology 1 year ago, so which is not normal. Normally, a medical doctor, especially a surgeon, has not to publish something against evidence-based medicine in a journal like Neurology in 2018. That means that we have a problem. And this problem is that we've forgotten the Hippocratic Oath. So, patient is unique, preventive surgery functionally applied to each patient because, of course, what we have to do is to put everything all together. Everyone is telling that. It's not true in practice. Never, almost. And then, to better understand, once again, not only the location, but the migration along the white matter tract, the kinetics, the genetics, also, in the end, you will have, but also using preoperative MRI with a high level. So we can put everything all together. And then to solve the equation in this patient at that time, but also to speak the same language. Everyone is speaking, no. Please show me the neurocognitive scores. Please show me the feedback by the patient 15 years later, subjectively, and by the family. Please show me the pre- and post-operative FLAIR MRI. No, it's never done. It's a shame. And then you will start to anticipate also what we will have to do in front of a patient for the first time, knowing that more or less I'm able to do that with my team 10 years in advance, but not 15 years. That means that 10 years later, sometimes I'm surprised, especially then, unfortunately, I must confess that I have recurrence after a very supratotorization with a perfect MRI for 10 years, and I would like to say to the patient, maybe 10 years later you're cured, maybe we can postpone the next MRI and so on. No, you cannot. The tumor will come back. So new frontiers, it's just interactions between diffuse low-grade glioma, but also what we will see in the second talk, how the brain is processing. And if we cannot understand that, at least with a humble level, because of course I have so many things to continue to learn, it's endless. Speaking about neurosurgeons, neuro-oncologists, radiotherapists, and so on, neuropsychologists, of course, then we cannot solve the equation, allowing you to have 16 years of median survival with 99% of patients enjoying normal life. And this is, of course, a multidisciplinary teamwork, but outside the guidelines. So sometimes we have maybe to accept to be a little bit a maverick. Thank you for the first talk, and And if we want now to discuss before connectomics. I'm fine, thanks.
This is an opportunity for ask questions from the people that are participating outside. We have neurosurgeons from Uruguay, Argentina, Brazil, Miami, that are just connected there. But of course, I want that you ask any question that you want to, or something that you want to share for this first session. I have two neurophysiologists here, and I want to hear something about you. What do you think? And in fact, how do you think that we can change what we are doing right now in order to try to reach this goal, in order to try to really understand the brain and to do more and more scientific and very maybe closer monitoring for this kind of patient, because in Colombia, as I told you, neuropsychologists is not people involved in our surgeries, but neurophysiologists, and we have two of them here that work with us very close. So I want to hear something about you or the neurosurgeons. I know, Guzman, you want to, or Dr. Velandia, what do you think about neuropathology issues and this kind of thing of these talks?
Excellent lecture. I learned a lot of the things, but I remember your words. The people of the neurosurgeon teams don't use the same language. This is the big problem, because the neurosurgeon all the time are thinking to remove the tissue. That's all. And working all the time, they use the technology to improve the results in the surgery. But forget all the time the basic of the neuroanatomy and the neurophysiology and the pathology. That is the problem. To try to the people improve your knowledge in that area. That is the basic problems. But because some people speak some topics and other people speak another topics. That is the difference. Don't speak the same language. I am surprised when you say burning the brain. I agree, completely agree. And I think the therapeutics in the brain tumors, all of the brain tumors are fatal tumors in this time. That is the problem. Different in the diffuse gliomas from the child's gliomas are very different. And in the diffuse gliomas, we have only three arms to treat the problem: surgery, radiotherapy, and chemotherapy. You say use very good resection to prevent use the another techniques. That is what I'm thinking.
I think that we have more. We have surgeries, chemotherapies, and if it would have been possible to use radiotherapies, I would not have this discourse. But I know that, except of course a re-irradiation very focally on one enhancement many years later, it's very difficult to re-irradiate the brain. So be careful, I'm not against radiotherapy because I know that some of my patients now started more and more to be irradiated, and I'm very happy, of course, when the tumor is stabilized, while it was not possible for me to reoperate or when chemotherapy was not efficient enough. But to postpone it, because the problem is that it's not radiotherapy burning the brain today, it's radiotherapists, because they are not understanding, but like so many neurosurgeons too. What we will see in the second talk, so the limitation of neuroplasticity, and I would like...
It's the same thing. Don't speak the same language.
Exactly. But if one radiotherapist would like to come really to Montpellier and just to speak about the limitation of neuroplasticity and to adapt the strategy of irradiation according to the knowledge of the connectomics, I would be so happy knowing that I welcome more than 500 departments of neuro-oncology, surgical, medical, neuroscience, and so on, for more than 50 countries. No radiotherapist came, never, never. This is the reason why I'm sometimes so angry, because I would like just to communicate in order to speak the same language, and then they will do what they want, but by adapting their strategy. They don't want, it's just the technology is beautiful. Yes, but if you irradiate very focally just the crossing between the I4 and the arcuate, you will destroy the language network of this patient just for 1 centimeter of tumor. So why not? But we have to explain that to the patient post-cons, and it's never done. And just to say also that I loved to work with a neuropathologist since the beginning, because I had the chance to be in contact with them since my residency, and I spent half of my time in neuropathological lab to discuss with them online, including also Catherine Dupont, who was a friend, especially at the end of his life. And now we continue to have exactly the same relationships with our neuropathologists. So don't worry, I love neuropathologists.
Doctor, very elegant lecture. It's very glad for me and for us that you stay in this country, so you are more than welcome. We know each other a few years, and when I knew you, the first thing that I was thinking of myself is that I found a person that thinks the same way. Because in my beginnings in neurosurgery, I've been neurosurgeon 10 years ago. It's only a fight about removal of the tumor, a supramarginal resection. It is still a fight right now, at least in our country. Mm-hmm. So we start to do it. As Gabriel mentioned before, I dedicate only to brain tumors and school-based. I don't do anything else. We have a team of neuropsychologists, dedicated anesthesiologists, physiologists, and neurosurgeon, and a whole team. So I have a tricky and polemic question to you. Mm-hmm. From 2 years ago to now, I was just in Buenos Aires 2 weeks ago, and there is one thing called Excellence Centers for Pituitary Tumors. There is a guidelines, and there is a lot of things that, of course, is polemic to some people that don't dedicate to one thing. But one of the things that they say is that they need to do at least 50 pituitary tumors per year. They have to do, a lot of things. So if somebody asks you what an excellent center must have and what are the requirements of the neurosurgeon, what will you answer just to try to follow that?
It will be in my second talk. In fact, first of all, to understand brain, not only by the neurosurgeon, but the neuropsychologist, the neurophysiologist, the neuroradiologist, and so on. And if possible, I know it's maybe to ask a little bit too much, but in a dedicated center, multidisciplinary center, I think that everyone should be PhD in cognitive neuroscience. And suddenly we are speaking like we will talk during the second presentation, and you will see that we have really the same language. So in fact, it's not related to the numbers. Of course, if you do just once a month is not enough. I would say every week, more or less, like in all kinds of surgeries. But I remember what I have been trained by George Oshman in Seattle for wake mapping 23 years ago. Finally, he did more or less 1 to 2 epilepsy surgeries a week, and it was enough. The goal was not to spend his life into the operating theater because he changed the world, and not only by telling you have to operate the brain, but also you remember, all of us, the diagram of the variability, anatomofunctional variability of language, because he thought a lot too. So I would say to spend 50% of your time outside the operating theater for a surgeon. And this is the reason why I told you, finally, when we met, I will go now to Dubai, to Singapore, because in the plane, I will write some papers too. And the goal is for me to think, and I will come back, of course, I will operate a lot, but based on not only my knowledge, but our knowledge integrated within the team.
Nice.
But you had two other questions.
Huh?
You had three keys of polemic, and you asked me just one question.
Oh, no, I will save the others for the next.
Okay. Okay.
I'm just... Is it working? Yeah. So I'm just curious about something that you said through your talk. So you made a lot of emphasis regarding the neuroplastic changes that occur in the brain after like a tumor is resected. So what I think, or what I'm curious about, is that is there any evidence that suggests that there can be neuroplastic changes while the tumor is growing? That means, like, say, for example, there's a tumor that's growing in the Broca's area, right? Is there evidence that can suggest that the Broca's area might, like, move to another close area of the brain where it was previously located, or the tumor is, or do you think the tumor is not big enough, like, to actually compromise the whole Broca's area and, like, make an impairment in the patient's speech? What do you think?
I will answer all your questions during the second talk dedicated to neuroplasticity, and you will see the tumor inducing modification of the map from one surgery to another one, but also probably the fact that we operated on, and probably the fact that we rehabilitated on the patient following surgery. So it's a mix, but I will show you evidences, of course, published in journal of most of the time neuroscience. So don't worry, I will show you in the second talk.
So the take-out message is that you can still resect it, and a speech function can be still preserved in the patient if those neuroplastic changes has occurred, right?
Yes, but in fact, you are speaking about Broca's area, speech function, and so on. You seem to have a localizationist view in your brain. I can see your brain because I am a mentalist, so I will try to destroy this view during the second talk, and suddenly you will see that all clouds will disappear. You are too under the weight of dogma of localizationism. Forget it.
Doctor,
Could you say the name and where you dedicated?
oh, my name? Dr. Duffau, thank you for your lecture. My name is Sandra Carrillo. I'm neurophysiologist. And I think the more frequent problem that we have during the awake patients is to measure the strength, because sometimes the patient get tired during the surgery, or they are sleepy because of the anesthesia. Do you have, or what method do you use to measure, to be more aware with the strength of the patient?
I will show you more also in the third talk dedicated to how I do it with awake surgeries and movies. But to answer your question, first of all, I have a good team, so I have good anesthesiologists. So that means that they have understood the principle. They're not afraid to have a full awake patient during the resection. So that means that, first of all, of course, if the patient is not able to be fully awake after the opening, you will have problems. So we involved anesthesiologists in this kind of processing. Second, you will see that I changed the paradigm of resecting the tumor, because I forget the tumor within the operating theater, but I do a disconnection of the lobe according to the functional boundaries. So that means that even in very big tumor, I can do that, as you have seen, in more or less than 1 hour. So that means the patient has no time to be tired. Third, because I have very good neuropsychologists, and in fact, the patient is not stressful also because he has no time, because he's focused on the tasks. And sometimes, I know that Mitch doesn't like when I say that, but I can be also a tyrant, like with small kids, you know, by telling, you are tired, I don't care, because we have to finish to remove the tumor, you can help me in order to change radically your life for the next 10 years. And suddenly the patient is telling, okay, boss. And again, you can work. So you see motivation, because I know more or less how to manipulate the networks involved in mentalizing. It's exactly what I will show you. So you see, it's a mosaic. There is no one trick. This is a philosophy, and of course, with neurophysiologists by using very, very low intensity of stimulation, which is very important also because I have no seizures intraoperatively. And you know that if you start to increase too much the stimulation, you can also induce, beyond the motivation of the patient or the experience of the neuropsychologist, by yourself as a neurosurgeon connected to the neurophysiologist, infra-clinic seizures, and finally the patient will not be able to help you because of your stimulations. So you see, in fact, it's really a full picture, but we will speak about that in the next talk. Next.
So we have time right now for a break, 15 minutes break. Oh, okay.
Ready?
Okay.
It's just a small technical question.
Small?
When you are deep in the temporal fossa, yeah. You can see as much patient you do that you have more feeling of pain. How do you deal with that?
Once again, yeah. I do not remove the tumor. I disconnect the lobe. Okay. So that means I will never remove T3, for instance, while the patient is awake, because I don't need it. Otherwise, I know that, as everywhere, I will induce pain related to the skull base, meningia of the skull base. I will disconnect the lobe from the so-called Wernicke's area to identify the IFOF, to open the ventricle, posteriorly the arcuate fascicle, and so on. And in the end, finally, I removed more or less nothing. But everything is disconnected. Then you can put the patient under general anesthesia because you have just to remove the lobe. So change the philosophy. Do not remove the tumor from inside to outside. Forget totally the classical view of brain surgery.
Yeah.
One good quality of life too. You can ask to Dr. Vargas. Not so bad.
And
yeah.
One thing is they are using always sleep as sleep. So that means that the patient remain asleep until they open the skull and are ready to open the dura. We're using the mask, laryngeal mask. I tried that here with the anesthesiologist. Some anesthesiologists can do that. Some are afraid to use that. So we need more trained anesthesiologists or something different, because it's different, you know, when you have the patient sleeping until they open, they understand that it's a short period of time. This connection is one of the best things to do the trick and then remove without problem. Because I saw that after you disconnect, they put the patient asleep and continue the surgery. So please, I let you know, we have something to drink here, some bread, bathrooms at the first 4. This is for the mans like me, 15 years old or more, if we need a bathroom. And see you here in 10 minutes, please. 10 minutes of break.
Okay. I will calculate what means 10 minutes in Colombia.
No, please, give an example, please.
I hope you enjoyed.
Hello. Okay, so we continue with the second session. Dr. Duffau is going to do a small talk on meta-networking of brain tumors and then some video cases, and then if we have time, some case discussion. So Dr. Ferreira, if you want to comment a patient, maybe we can do that at the end if you want to give an example after this talk. Okay?
Thank you, sir.
Let me. After this meeting, we go to La Puerta del Sol. I choose La Puerta del Sol restaurant because I asked Dr. Duffau what he wants to eat, and he wants typical food from Bucaramanga, Colombia.
Because the steak is very hard and dry.
I will try, because I love meat. What I love is, you see, to challenge dogmas. So maybe I will be more plastic tomorrow, or I will be sick. I don't know.
There are in here the canar, il n'y a pas de canar, de cassoulet, pas de tout.
I will try to be flexible.
Okay, so just to start with the second session, we'll go until 7 p.m. to 7:30. It depends on how if we are not tired, we continue 7:15. It depends.
You will tell me when you would like to interrupt, because of course we can speak all the night, and the goal is first of all to now see this neoplastic phenomenon more in detail and to show cases. So maybe I can have the slide, please. Otherwise, without the slide, it will be complex to understand. Thank you, yes. I would like to introduce a new concept, even in neuroscience, and we're finishing this paper, which is in press now in a physiological review. So that means that you see, you can be, in fact, also a neuroscientist involved in the physiology based on what we have learned from stimulation mapping, speaking about this meta-networking brain. So definitely, I'm sure that you understood, at least I will try to demonstrate that by showing cases and evidence that there is no one Broca's area, no one Wernicke's area, and that, in fact, neuroplasticity explains why it's possible to see patients everywhere in the world with this very big tumor and finally doing well, at least according to the classical neurological examination, because once again, if you do a very extensive neurocognitive assessment, they are not well. And you can use this plastic phenomenon, in essence, induced by the tumor. You have the proof. In order now to do very extensive resection, and I will be very provocative by showing you patients in whom I did a bifrontal lobectomy. And I can tell you that if we were able to publish these cases in Cortex or Cognitive Neuroscience journal, that means that they are asking for 5 hours of cognitive assessment regarding also the mentalizing, namely the behavior, the emotion, the higher cognitive functions. And I can tell you that these patients are enjoying normal life, driving, working, and normal executive function scores, and so on. So that means that you have the proof that, in fact, we can really deal very far with brain plasticity. If you have a slow-growing tumor, or if you repeat surgery rather than to induce a very, very big deficit initially, like a stroke, and finally maybe the patient will not totally recover. But it's just possible if you are in this state of mind. And I participated when I was younger during my PhD in this meta-analysis of the literature using fMRI in healthy subjects, and you can see that there is no one area corresponding to Broca's ear and one corresponding to Wernicke's ear. This is a network. It's not my view. This is the physiology. So this model should be burned. And of course, you have connectivity just in between, and it's exactly what we have to identify during our surgery. And you will understand better probably why I do not use neuronavigation or intraoperative MRI and so on, because I have this kind of model I wrote by myself in Nature Reviews, for instance, regarding the organization of the brain. So that means that you can do very extensive resection. You can triple the median survival. You can do bifrontal lobectomy or resection within the insula, Broca's area, blah, blah, but also to publish this kind of model for neuroscientists, because in fact, we are connected to the brain. And unfortunately, 95% of neurosurgeons I know have not yet understood that they could be neuroscientists, because it's a unique opportunity to be connected of the central nervous system of human being in vivo. And we are not doing that. So that means that in fact, we are destroying neurosurgery, brain surgery, by being just a robot doing the surgical act by telling, I would like to be skilled. I'm not skilled, I don't care. It's not a technical issue, it's a conceptual issues. According to that, some overlapping, you have understood why we have to do cognitive assessment in all patients, and you start maybe more to understand that tumors are migrating along the white matter tract. You can see here in the arcuate fascicle, the inferior fronto-occipital fascicle, the incinate. It's not my imagination. And according to that, we demonstrated that, for instance, if you had, before any treatment, a diagnosis, invasion of this fascicle, the patient will have already some semantic disorders. And you cannot know that if you don't do a cognitive assessment. And why it's important? Because you can start to predict how much you will remove. So finally, you are preparing the surgical act by doing that. You have understood that seizures is the first limitation of neuroplasticity, and you have understood that we can change radically the natural history of the disease by changing the survival more than 15 years. So we have to preserve the quality of life. It's exactly what we have seen, mapping techniques. And now I will detail a little bit more because we are dealing with eloquent areas, but I will tell you, I don't know what means eloquent areas. I know what means eloquent networks. It's not the same thing. So according to that, speaking about language as we have seen, we have a connectivity underlying this language, and if you start to model this connectivity by yourself, then you will have these 3D representations in your own mind during surgery. Now, a step more. You can use functional imaging not in order to pre-plan your surgery because it's not reliable at the individual level. There was a recent meta-analysis about functional imaging in language, and the reliability is around 60 to 70%. Of course, you cannot make a decision according to this low reliability. So what means here? When you do a theory of graph connectivity, you have one hemisphere, another hemisphere, you have here a tumor within the supplementary motor area. You can see that before any treatment, the brain reorganized. You would like to see something very strong. And I will show you many cases, not just cases, I mean studies, published in journals dedicated to neuroimage and neuroscience, before and after. Also surgery, and you will see that surgery will induce a modification of the connectivity within both hemispheres, explaining why there is no one hemisphere language dedicated, left dedicated to language, and right with no use. You can forget it. And I don't know how to explain that to neurosurgeons. Why they know in fine that this is the truth, because for them, they need both hemispheres connected thanks to the corpus callosum. But for their patients, they don't care, because in the right, they will say, oh, what I want is just to identify the primary motor cortex, the cortical spinal cord, and I don't want to induce any hemiplegia. Yes, but the patient is not himself anymore. So, definitely, I am PhD in functional neuroimaging, so I can say that imaging is not reliable. But I will show you that I used for 20 years neuroimaging before and after surgery, and we demonstrated that we modified the connectivity thanks to this awake mapping. I will insist more on the next talk about how I do it and with cases. But what I would like to say is that we can do cortical and subcortical anatomo-functional correlation in real time in a patient during surgeries, and not just cortical mapping, once again, but throughout the resection in order to disconnect the lobe. And according to that, no pain, and the patient has no time to be tired. So it answers a part of your question. Definition of the quality of life by the patient himself, we have seen that. But now I will introduce also, according to the social and environmental aspects. In other words, I'm sure that the law, as I said, is not exactly the same for you here, according to the fact that the patient maybe can have hemianoptia and can drive. In some countries, in North Africa, for instance, is possible. In France, in Europe, it is not. So that means that according to the law, you will do something different if the patient would like to continue to drive, for instance. Or I know that in US, the vast majority of patients will not benefit from postoperative cognitive rehabilitation because it's not reimbursed. You imagine, you have an intraoperative MRI and you have no money just in order to rehabilitate the patient, while in fact it has been demonstrated that rehabilitation will provide all chances to the patient to return to a normal life, not intraoperative MRI, because intraoperative MRI show you the flare, but we have demonstrated that the flare is not the tumor, it's not the disease, and the flare is of course not the function. So how can you say it's too expensive to rehabilitate a patient? Nonetheless, that's true in US. This is not true in Europe. So we have to adapt to each country, and you have yourself to be plastic in order to take some of this concept and to say, yes, but here we cannot apply directly. We have to change the modalities. But the philosophy should be the same. So this is maybe one of the most important slides. How to explain to the surgeons, I say that, I remember it was 5 minutes ago, but I have to say it again, that the left dominant hemisphere is not dominant. And that we have not to wake in the left in order to map language and nothing in the right. If you think that, I'm sorry, I will be a little bit provocative, but I like to say that, put screw in the spine. Don't touch the brain. Why? Because you can see what are in the so-called right non-dominant hemisphere movement. You can induce hemiplegia to a patient, but you will see that we have to control movement. We spoke about music and piano player recently with Dr. Vargas, and it's totally different to be hemiplegic or to play concerto of Rachmaninoff. But some patients would like to be able to do that. Or surgeons I operated on in my life, the first question was, do you think that I will be able to reoperate after your own operation? And suddenly they need bimanual control. It's not just to avoid to be hemiplegic. And suddenly you will not use the same networks. Spatial cognition to drive, avoid hemi-neglect. Social cognition, what we will do this afternoon, this evening, to discuss all together and to maybe make politics. How is it possible without, I know that you will have an important appointment this Sunday, you will use social cognition and you will use the vast majority of your right non-dominant hemisphere. Will tell me maybe it's not a good idea, so you can decide. So do lobectomy under general anesthesia if you don't want to speak anymore about social cognition. Non-verbal semantics. 90% of the communication is non-verbal. And we would like just to preserve language. Yes, but this is not the real life. It's just a part. Executive function, working memory. You are playing a lot, I see that it's probably a tradition in Colombia with your iPad. Are you sure that you are able to do two things really simultaneously? Or finally you disconnect a part of your network, just focus on your iPad, and finally, the next slide, you will say, I understand nothing. So, for your patient, it's the same thing. conscious information processing, you will see that we can disconnect the patient from the environment during surgery. And most of all, the personality, because human being is, first of all, emotion. And more than half of my patients are asking me before to be operated on, okay, you're a famous surgeon in this field, I'm sure I will not be hemiplegic aphasic, but do you think that I will continue to be myself? So the answer is we have to adapt what we will do into the operating theater according to the real needs of the patient, whatever the side. For instance, to do two things simultaneously. Into the OR, exactly what I spoke about, you with listening the talk and playing with the iPad. If it's true for you, it should be true for your patient. Otherwise, you will say, yes, my patient is not hemiplegic aphasic, but he is not able to do two things simultaneously. Semantic association task. For instance, you have a cat and a dog and a car. And of course, you have to associate semantically the car, no, the dog and the cat. And the patient can show the car, can say this is a car, and finally he understood nothing. More and more, after telling me that I was also a little bit crazy by doing so many tasks into the OR, which is a paradox because they told me the same that I was crazy to remove so much the tumor and the brain, but finally to find a good balance, you have to do two things. Antagonist a priori, simultaneously, and to adapt using the plasticity of the brain, which is here in order to restore our mistakes. I can see that in the literature, more and more, whatever the country, you can see the working memory, able to maintain in your mental imagery what you have listened and to decide if you should remember or not. The Stroop task, I will not detail, of course, otherwise we will have all the night. So suddenly, everywhere, in each country, you have surgeons telling, oh, we have to preserve the function, and especially the executive function and the emotion. Oh, really? This is a possibility to map and monitor what we call the mentalizing theory of mind. In other words, the possibility to feel, to perceive the emotion of others. But higher level, you can also attribute the intention of others. This is exactly what we are doing in society. So you can ask to a patient to recognize the expression, the emotion expressed by the face in front of you, just using higher. And this is very difficult to do. But this is absolutely crucial in order to enjoy this normal social cognition. If the patient asks you, if he's telling you, I want to live longer, please do a supratotalization, and finally, I hate people, I don't need to work with them, okay. I do not decide for them, I offer the choice. And now you understood that we will apply the same concept we have seen, cortical mapping, subcortical mapping, in order to encounter the fibers. And so how is it possible to say I will awake the patient by doing a battery of tasks according just to the cortical location of the tumor? Because if you do a frontal lobectomy, or if you remove the insula or a temporal tumor and so on, in all cases you will be in fine into the contact of the inferior fronto-occipital fascicle, so you have to incorporate the semantic association task. Otherwise you will cut the pathway, or you will not push enough the resection. So once again, resection according to functional boundaries and what we have learned by applying this concept. First of all, Broca's does not exist, and we published that in Brain. So that means that it's not my imagination. Neurologists have accepted the principle, and I will be so in Dubai in 3 days in the World Congress of Neurology to explain how the brain is processing to neurologists, and by burning the localizationism. You are a lawyer, you can have tasks of judgment. You are a mathematician, calculation. You are a dancer in the right non-dominant hemisphere, spatial cognition, line bisection task. If you deviate right, that means that you stimulated some networks involved in the cognition of the environment, of the space. working memory to do many things simultaneously. If you are, for instance, a director of industry, if you are a writer, syntax, I operated on this writer, and he's very famous in France. I removed Broca's area and the left frontal lobe, and he was able to write 3 other books, and he told me, finally, I'm not better or worse, I'm myself. And in all cases, theory of mind, because human being is emotion, first of all. And we don't care. No, we're afraid about that. As a neurosurgeons, we don't want to think about the emotion of our patients. Oh, it's a problem for a neuro-oncologist. I said something against neuro-oncologists during the first talk, but now I have to say something against neurosurgeons, because it's too easy to say to neuro-oncologists, now, you will take care of my patients, and if he's depressed, I don't care. It's not my job. No, but you were responsible by cutting the right inferior fronto-occipital fascicle. So the cortex is more or less nothing, because very plastic, and because you can remove the vast majority of the cortex, the patient will recover. But you cannot cut the highways, otherwise everything will be disconnected. So you have to do dissection by yourself. I will tell it again. Your navigation will never give you the knowledge of the structures of the brain. You think you know the anatomy for most of neurosurgeons. This is not the truth. Just the sunsai and the gyri is 10%, the tip of the iceberg. You can use, of course, tractography, not at the individual level, but to build this 3D representation. And now you are into the OR, and you will do stimulation not only at the level of the cortex, but also the white matter tract, knowing that patient is still alive, is still, of course, alive, but also awake, and that you have this feedback. And then what we learn about that? Speaking about the negative motor network, if you want to have bimanual coordination with a high level and to play a piano, because in fact I'm first of all a pianist, you have to preserve the premotor cortex. Yes, but you will not remove the tumor. It depends, because the tumor will induce some modification of the map. Otherwise, the patient will not be able to play piano before to come to meet. But you have to preserve the connectivity. Do you know that? Of course, we published a lot in human brain mapping, in cortex, in blah, blah. I will not insist about so many papers, 400s, dedicated to the fact that you have the frontostriatal tract and the frontal astron tract. If you don't know them, you cannot preserve the bimanual coordination. For instance, the fat is connected the supplementary motor area to the ventral premotor cortex. I have no time to insist, but if you stimulate it, you will induce mutism. Say, but it's a SMS syndrome. No, it could be a disconnectionism. So we modeled recently this negative motor area, and you can see, in fact, areas and network. That means that, in fact, we don't know the connectivity, even in the field of DBS. Recently, I gave a talk in a society in another country dedicated to stereotactic and functional neurosurgery. And I said, finally, you don't know what you modulate by putting your electrode within the GPI or STN. I have induced a permanent, at least one time in my life, stuttering by cutting the fat. Now I know. I needed 15 years in order to understand, finally, what I did 15 years ago. And the patient was able to live for 14 years, and finally was not aggressive against me because he was alive, but he told me I tried to compensate by stuttering, but it's a little bit disabling in my life. Now, I can propose to the patient to avoid that, or not, if they want to remove more tumor. We know that we have frontal eye field involved in attentional processing, but also oculomotor fields. That means that you can stimulate the white matter tract at the junction, more or less, because it depends on each patient, of the precentral sulcus and the superior frontal sulcus. In the depth, you will stimulate, and the patient will have oculomotor movement, which is a real problem in order to have, of course, attentional processing, which is intact. And this is crucial just to drive, for instance. Recently, we published in Brain, in fact, it's now published, that when you remove a parietal lobe, of course, you have to be careful about the somatosensory proprioception and superficial feeling. But you can also have some problem of movement, and when you stimulate, the patient will stop to move. And it could be more complex because you can induce permanent modification of the awareness of your own body. For instance, I have a patient, and I understood that many years later, also walking like this. Say, why? Your neurological examination is perfect. Yes, but I have the awareness that one leg has not exactly the same length in comparison with the other one. I changed her body representation. So, of course, you can say, I'm happy, this is a beautiful result. No, we have to ask to the patient. How do you want, if the patient is not awake, to map the visual field online, especially regarding the optic tracts, including in the so-called right non-dominant hemisphere? Because if you have a left hemianopia, in France, once again, you cannot drive. And the lawyer will not tell you, oh, it was the right hemisphere, so no problem, the patient can drive. We published in Science that when you stimulate the part 2 of the superior longitudinal fascicle connecting the supramarginal gyrus with its junction with the posterior part of the superior temporal gyrus and the premotor area, then you will induce deviation of the line bisection task, inducing hemi-neglect if you continue to cut it. That means that it's both science and, in this case, it was the first 15 years ago. She was a dancer, and she told me, you have to remove the right parietal lobe, but I would like to dance. I have a gala in 3 months. And she was able to do that. Regarding language, now I'm sure you understood that there were, in fact, many subpathways connecting the so-called anatomically broca's area, the pars opercularis, not with the superior part of the posterior part of the superior temporal gyrus, but in fact the posterior part of T2 and T3. It's very known in the scientific literature. It's not known by neurosurgeons. But it's not my view. It was demonstrated using DTI, it was demonstrated using dissection, and of course intraoperative mapping, because if you stimulate the so-called arcuate fascicle, you will induce conduction aphasia with phonemic paraphasia and repetition disorders. You say, oh, I don't care, I can operate in this location without knowing that, I have just to take my neural navigation. And you think that neural navigation will tell you, be careful. You arrive into the contact of the pathway, which will induce phonemic disorders for the patient. And the patient, like here after surgery, oh, it's not an issue. Who are you? Well, you see, my patient is well. Is it enough? Syntax. We spoke about that. You have a writer in front of you. He wants to continue to write normally. You have networks at the level of the superior longitudinal fascicle. I cannot detail because there was also another sub-network involved in language switching. Exactly what the translator is doing now is using different languages, and je peux décider d'un seul coup de me mettre à parler français. That means that my executive control can modulate not some areas, but different subnetworks. If it's true for me, even if I have a poor English, I'm sorry of that, because I'm French people. But it's true for my patients. And some of them told me, I speak 3 languages. Or I operated on some translator also. And they told me, if I'm not able to do that, I will lose my job. The inferior fronto-occipital fascicle. This is the main fascicle in human being. There is no IFOF in monkeys, and this is the reason why monkeys is not able to have this level of abstraction regarding semantics. The uncinate itself, you can cut it. You have a risk to have problem regarding proper name. Retrieval, and I have this problem, so I know that you can enjoy my life despite this problem. But it's just my subjective point of view. You have to explain to the patient. The ILF, the inferior longitudinal fascicle, the more basal, including in temporal lobectomy, of course. If you cut the anterior part, you will have an increase of reaction time regarding the naming tasks. If you cut the posterior part, you will induce alexia. We modeled recently in human brain mapping the connectivity underlying reading. It's not just one area, the visual waveform area, that's it. No, you have so many connections, and you can map them and monitor them into the OR. We say it's too much. Yes, but the patient told me I don't want to have alexia. But because the brain is beautiful, the IFOF has some cortical termination posteriorly and anteriorly, allowing you to compensate the fact that you can cut the anterior part of the ILF, as I said, and the incinate, and the price to pay will be to have an increase of reaction time for lexical retrieval. If the patient can accept that, he will not be aphasic, and you can do a very extensive lobectomy, anterior temporal lobectomy, and it's exactly the principle of anterior temporal lobectomy in the so-called left dominant hemisphere in epilepsy, independently of low-grade glioma. We are not speaking just about oncology, but it's better to know what we are doing. You remember, you have not the right to go beyond the ventricle. Of course, you have the IFOF. So it's better to know that. Yeah, I know my anatomy, I know the ventricle, but the ventricle, there is nothing, it's just CSF. You have to see the connectivity around. Recently, we published in neurology that we can have also a network involved between not only the SMA or the dorsolateral prefrontal cortex, but the head of the caudate, and very important in order to avoid perseveration. You show a cat to the patient, he's telling this is a cat. Now you show a dog, you stimulate the head of the caudate, and of course you induce a transitory disconnectionism, cortico-subcortical syndrome, and the patient will not say this is a dog, but still a cat. Is not able to forget the past. This is exactly one of the symptoms in the frontal syndrome. And we will continue to believe, it will be exactly what I will demonstrate to neurologists in 1 week, that it's because we removed the frontal lobe. Not at all. I have shown some patients with bilateral frontal lobectomy, but I preserved this cortical connectivity posteriorly. If you don't do that, you will say the patient was not able to recover before it's totally crazy. Yes, but preserve the fat, please. So I will not insist, but you see this kind of model we can now published in Physiological Review. So in fact, the kind of Bible how the brain is processing. And never intraoperative MRI, neuronavigation robot and so on will give you this kind of information because they don't know. They are telling just you're here, but I know where I am. I'm not lost in the brain. If we go beyond, the IFOF has different parts. One dedicated to verbal semantics, so paraphasia, but the other one dedicated to non-verbal semantics. Remember, I told you that we can understand 90% of the word without speaking. So if you put everything all together, this is the reason why we are humans and not animals. I mean, of course, animals can communicate. This is not the point. But they cannot be able to understand how their brain is processing in order to communicate. In other words, knowing of knowing, metacognition. I know what I know, and I'm aware about that. In other words, you can ask to the patient, I told you just before, you have a car, a dog and a cat, you have to combine semantically, and he will show you the car. So he understood nothing. And now you ask the question, why you say the car? Because this is a car. No, but I ask you to combine two pictures semantically related to animals. And he will say, no, I will explain why. And he will try to find a good excuse, reason, argumentations in order to demonstrate to do that it was not crazy. While in fact, during stimulation, it was not semantically related to himself. Problem of metacognition. Of course, we can monitor that into the OR. And I will tell you that the right IFOF is crucial for that. So if you do surgery in order to push the resection supratotal, okay, Duffau convinced us we have to remove completely the tumor to take a margin because I would like to have patients living 20 years. It's absolutely fantastic. Yes, you cut the IFOF and the patient will understand nothing. But you can continue to show in meetings, the patient is not hemiplegic and he will answer to you. Please, can you count? 1, 2, 3, 4. Can you understand something? Yes, of course. This is the demonstration that the patient is well. That's crazy. Now, why both I4s are connected all together? Because we published recently also in another paper in neurology that the anterior cortical termination, the most important, is at the level of the dorsolateral prefrontal cortex, namely the posterior part of F2. And why is important? Because you have the dorsal pathway and the ventral pathway. So hub, allowing the interactions between two main pathways, verbal, non-verbal, bilateral organization. And you will tell me, I will show you a case. I remove completely the right temporal lobe, and you can see on the postoperative DTI that I got the I4 and the neuropsychological examination is normal. Yes, because this patient was able to compensate thanks to the bilateral organization. My question will be, are you able to reproduce that in 99.5% of cases or not? Because just one case is not a prospective collection of data with 1,000 cases and 20 years of follow-up. Why now to map the emotional aspects? I did this kind of mistake when I was younger. So I don't say, yes, I understood everything. I said, I had a first life, a second life. The first, I want my patient's life, not hemiplegic, not aphasic. I achieved this goal 10 years ago. And then I started to increase the level and to be honest with myself and my patients by telling to my neuropsychologist, please, can you examine them with a higher cognitive and emotional level? And they told me, you are a great neurosurgeon, so your patients are alive, it's beautiful, but I have the regret to tell you that they are not well. Oh, really? Yes. For instance, some people who became more or less autist-like, psychotic-like, and so on. This is a teacher who thought that people in the floor would like finally to be aggressive against her. Okay, so we said, first, is it possible to demonstrate that? Yes. When you have removed too much the right inferior frontal gyrus, I will be a little bit localizationist, but in the right non-dominant hemisphere, if you remove the right Broca's area, you will induce more frequently mentalizing deficit. It's exactly what I did when I was younger under general anesthesia, and I was wrong. So I said to my colleague, is it possible now, because the patients are living longer, not aphasic, not hemiplegic, blah, 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 to preserve not only the executive functions, but also the emotion. And then he introduced these tasks, and suddenly what happened, we understood that there was an involvement of the inferior frontal gyrus, but also of the dorsolateral prefrontal cortex. You remember the hub bilaterally organized between the dorsal phonological loop and the ventral semantic loop, and the superior temporal gyrus. And you can see, in fact, a network. And now I said, I have understood. I got probably this network, and if you know your anatomy, you will see one pathway, the right inferior frontooccipital fascicle. But it's not enough. This is, in fact, the right inferior frontooccipital fascicle. And I said, I have to stop earlier in the depth in the right non-dominant hemisphere to preserve the mentalizing. But we understood also that there was another level, as I told you, the possibility to interpret, infer, attribute the intentions of others. And this is not the IFOF. This is the singulate at the level of what we call the Default network. Then we have to stimulate also that if you want to preserve this high level of social cognition, except if the patient is telling you, I don't care. You have to explain everything. Otherwise, you are not in agreement with Hippocrates, the informed consent. How do you want just to obtain a signature with all this knowledge by telling you have a brain tumor, I will operate you, don't worry, you will not be hemiplegic, except 1% of risk maybe, and that's it. We are not honest. So if we are not honest, it's because maybe we have a problem of mentalizing. Because, as you understood, I had trained many medical doctors, and of course they benefited not only from cognitive assessment, but also mentalizing assessment. In half of cases, they had no empathy before surgery. So that means that my question was, how are your own patients? And of course, they don't know. because they don't care. One step more, if you stimulate during surgery this posterior part of the cingulate, so of course with a disconnection of this wound network, the patient will tell you, like Alice in Wonderland, I don't know if I am myself anymore. I don't know if it's the truth or dream. I don't know. Okay, I will stop here. In other words, we start to model now the so-called right non-dominant hemisphere. You see? Just the primary motor cortex and cortical spinal tract. So you have no risk. You can operate this hemisphere with this connectivity under general anesthesia. Never your patient will have any problems. Of course, it's ironic. So why finally the patients are not so poor? Because you have brain plasticity, able to compensate, especially when you have a tumor. So now the link with the low-grade glioma, with a slow growth, you see why it's very important also to calculate the growth rate. It's not just for oncological issues, but also for functional issues. Because what we demonstrated recently, also published in Neurology, is that in fact, if you look at the contralateral insula before to operate a patient, you will see that the morphology is increasing over years to compensate the tumor, the contralateral hemisphere. So there is a modification of the anatomy related to the growth rate of a low-grade glioma. According to that, now you can do a pre- and post-operative fMRI, and what will happen, especially following SMA syndrome, for instance, you will have a contralateral compensation, but still the primary motor cortex, the somatosensory re-entry, and you remember the control by the parietal cortex. And now you can see the wound network, and you say, okay, I understand why the patient recovered. So now, to answer your question, first surgery, primary motor cortex. I stopped here. 5 years later, modification of the map. You would like to see modification of the map. I have hundreds of patients like this. 4 years, 8 years, and so on. And prove it. Of course, I removed it, but because I preserved this connectivity. And you can see now the densification of the connectivity. If you cut just this, the patient will not move anymore. Another example, this is the club of the hand, the central sulcus, the precentral sulcus, the precentral gyrus. She's a guitarist. This is this level with the club of the hand removed, of course with a brain tumor. You would like to see more examples? This is the Labbé vein, who said we have to stop the left temporal lobectomy according to the Labbé vein. I'm not speaking about vascular surgery. I'm speaking about the brain. And of course, you can go behind. It depends on each patient. But in all cases, by preserving the ILF, the IFOF, the arcuate. Now you have to see in your mental imagery. But unfortunately, I'm sure that so many neurosurgeons, especially in the young generation, don't know the anatomy. So they will take the navigation by telling, ma'am, where I am in the brain of this patient. Stop. You would like to see more examples? First time I operated on this patient with left temporal lobectomy. I was young, enthusiastic, and I say, I will remove completely the lobe. No, the brain told me, no, you will not remove T2. You will not remove the arcuate. You will not remove the uncinate, and so on and so on. But because I hate to lose, the patient enjoyed my life. We avoid radiotherapy, and I came back 10 years later. You can see what happened. Now you have the arcuate, the IFOF, nothing, because modification of the map. And the patient was able to continue to enjoy normal life. You want Broca's area? What happens? This is the ventral premotor cortex. You remember the cortical atlas we published in Brain. In fact, if we want absolutely to identify an output is at the level of the lateral part of the precentral gyrus in 100% cases, in the left or in the right. So you can remove, of course, Broca's area. And you will tell me, yes, but it's because there is a tumor. Yes, but in the atlas, because I mapped very frequently Broca's area just for fun, because I opened and the patient was awake, there was no tumor, and what happened, in 90% cases, I did not induce any speech arrest. So I have the proof, and this is the reason why in brain, they were obliged to recognize the truth. But sometimes you can lose also incidental discovery by a radiologist. He did the MRI himself after a marathon because he had headaches. And finally, he identified this tumor. I removed the tumor, but I say I have the regret to tell you that I left a small but objective residue at the level of really Broca's area, because in this case, what happened, I had semantic disorders at this level. But of course, no radiotherapy, blah, blah, normal life. And I came back 7 years later, and this time I removed the so-called Broca's area completely with, of course, now you have understood the IFOF running to the dorsolateral prefrontal, the posterior part of the F2. And the patient continues to enjoy normal life. How to explain that to your oncologist? How do you want to do a trial with that? It's simply impossible. This is the negation of the brain plasticity and the human being itself. And I will tell you why I was able to do this kind of extensive resection, because initially I did a left lobectomy, and the tumor, I don't know why, unfortunately, but decided to come back through the corpus callosum, the forceps minor, into the contralateral hemisphere. And 10 years later, because the patient, in the meantime, compensated, he had, of course, rehabilitation, and because it was a slow-growing tumor, and because it was not irradiated, then I was able to do this very extensive resection published in Brain and Cognition, so we cannot lie. It's not just us, the surgeon decided the patient was well. One step more. I am not a good neurosurgeon. I am not skilled. I hate vessels. I don't want to take any risk. I want to tend toward 100% of recovery. So, in other words, I will never split the Sylvian fissure to have an access to the insular tumor. And I will tell you why, because we made recently a review of the literature, and the great neurosurgeons in the world had 5 to 10% of permanent deficit related to vascular problem. I have less than 1%. So forget to be a surgeon if you want to operate the brain. This is the message. Because what I do is to do a transcortical approach, subpial dissection, no coagulation, you will see that in movies, no spasm, then the Anderson came to check. At noon is finished, and the rate of permanent deficit is 0.5%, going through the cortex. And what is the name of the cortex in the left so-called dominant hemisphere in front of the insular tumor, insular area? Broca's area. Broca's not invaded. This guy is crazy. He will not remove Broca's. Oh, he's removing Broca's. This is a crime. But the patient is well. How is it possible? It's possible because I'm doing that also in the right non-dominant hemisphere. And everyone will apply this concept in the right non-dominant hemisphere because suddenly you have no risk. But what I told you is that in fact you have more risk to change the personality of the patient for the next 10 years in the right non-dominant hemisphere rather than to remove Broca's in the left. Of course, if the patient is awake and you adapt to the cortical mapping and then the subcortical electrophysiological and cognitive monitoring. Once again, in the literature, actually, 5 to 10% is not my opinion, just facts. I have less than 1%. Do you want 5 to 10%? Do you want to have less than 1%? So never split anymore the Sylvian fissure. I know they are surprised most of the time when I say that. Remove Rolando also. How? It's possible. Because you can see now the frontal striatal tract. Try to imagine. The pyramidal tract. The SLF. The somatosensory tract. A little bit under, of course, the optic tract, and so on and so on. If you cut that, the patient will never recover. If you don't cut, the patient will be like you and me. Don't cut the SLF. The limitation is white matter tract. So remember, gliomas love to migrate along the white matter tract. The limitation of neuroplasticity. No, don't admit that. So please irradiate. No, it will burn the pathway too early. So what I can do? Operate earlier. Yes, but you have already a migration. Do chemotherapy, induce shrinkage, and so on and so on. You see that everything finally now is logical. Parietal lobe is not an issue. Yes, but I preserved a little bit part of the cortex, as you can see here. I can be very aggressive. Why? I'm not really skilled. I'm not really a neurosurgeon. Have you already performed this kind of very extensive resection in your life, in patients enjoying normal life? No, my patient did not enjoy normal life. He was not hemiplegic, of course. He was able to speak, but he had a depression, because I did that when I was younger, and I understood many years later that I cut the right inferior frontooccipital fascicle. And is it possible to avoid that today? Yes. You have just the choice. You cannot remove the corpus callosum. Really? Who say that? I mean, this patient was able, because she was a famous pianist, now she died finally because I published many years ago, to play this Rachmaninoff concerto for piano and orchestra 3 months following surgery. This is this level of recovery, okay? And not just the patient is not hemiplegic. And the impresario told me she played better. And I understood that I made a mistake regarding mentalizing. But in her case, it was something positive. Don't do that without controlling. So now you have understood 800 low-grade glioma, mortality 0.5% of permanent deficit, that's it. 30% of improvement, impact on epilepsy. Now everything should be clear, and of course you change radically the median survival, not against the quality of life, because we have understood the principle of parallel distributed large-scale cortico-subcortical networks. This is not just a big sentence. This is not neuroscience. This is the pre-planning of each of your surgery adapted to each human being. And now you can see not only before surgery, but after surgery, in this case with SMA syndrome. And you can see that following surgery, we changed radically the connectivity between the right and the left. And this is now so many pre- and post-operative functional imaging study. During a supplementary motor area syndrome, you know why the patients have difficulties to move and to speak? Because there is a decrease between both hemispheres of the communication. But if you do not cut completely, at least, the corpus callosum, what will happen? A re-increase of the interhemispheric connectivity. And you can push it thanks to post-operative rehabilitation, except in some countries because cognitive rehabilitation is not reimbursed. So that means that the plasticity will not be so efficient because you don't push it until the limitation. So the patient will not totally recover, but we will say, okay, he had a brain tumor, so finally it's acceptable. I think that in San Francisco, during this meeting, I heard maybe 100 times it's acceptable. For who? For the neurosurgeons. I will go beyond. When you do this kind of lobectomy, you will change also the connectivity between not only the cortex and the deep brain nuclei, but also the thalamus and the cerebellum. And we can see that thanks to pre- and post-operative resting state fMRI for movement, but also for language. We published recently this paper, and we will have another paper now in press, in Neuroimage Clinical, with pre- and post-operative functional neuroimaging regarding language. And you can see the modification also of the connectivity. How do you want to operate if we cannot control that? And we did that also for the attentional network. Oh, attention is just, this is absolutely crucial in order to enjoy normal life. And we can control that into the OR and to model what happened before and after surgery in the modification of the connectome. One step forward. We can do that also for the metacognition, the knowledge of the knowledge. It was done. We have this level of knowledge today. Recently, just past week, we published in Neuroimage the most extensive atlas of the human brain in the MNI template with almost 2,000 sites of stimulation, positive stimulation, whatever the function, if I can say, movement control, language, semantics, emotion, executive function, and so on, both at the level of the cortex and the subcortical level. So it will be open for everyone, especially for neuroscientists, because this is not just a network like you can see on fMRI, but the crucial areas, structures, networks. And this is the reason why we can put everything all together, as you have seen, except the fact that my papers published in Nature 5 years ago is already obsolete. Because I have understood the constraint, the limitation, so the minimal common brain. We have published this atlas of neuroplasticity, and you can use it because I have in my mind, and this is the reason why when I meet a patient for the first time, I can predict more or less 5% of error if I will remove 90%, 95%, 120%, and so on. And I know that because I put that in my letter during the first consultation. I will remove approximately 95% of the low-grade glioma. You see the relationships with the natural history of the disease? And I can predict if the patient will keep some degrees of deficit or not, according also to the preoperative neurocognitive assessment. Remember, if you have a tumor, it's very practical. It's not practical, we understand nothing. It's practical. Imagine the tumor at the level of the anterior temporal lobe in the left dominant hemisphere, blah, blah, according to the classical view of brain processing. I told you you can cut the ILF, you can cut the incinate, you can do this kind of lobectomy. Okay. But are you sure that the patient will completely recover? It will depend on one thing, the invasion before surgery or not by the tumor of the inferior fronto-occipital fascicle, which should compensate this indirect pathway. So if there is already an invasion, probably the neuropsychological assessment will say, be careful, some semantic disorders, and you have to be honest with the patient by telling you will keep some degrees of deficit. Of course, not speaking about language, but reaction time. So in this case, you can discuss with the neuro-oncologist in order to do earlier, maybe, chemotherapy in order to shrink, not at the level of the lobectomy, in essence, but the IFOF. And then the radiotherapist will arrive by telling you, I can irradiate it with a beautiful technology. You know, I can be so focused. But you cannot irradiate the IFOF. If you irradiate the IFOF, I can cut it. The patient has already some deficit. You will suddenly see a decline of cognitive function. So you see why it's really this kind of diagram very, very practical for radiotherapy of gliomas. But how to explain that? And now to finish, the synergy between different networks and not just subnetworks. It's exactly so, once again, what we will, I hope, publish next year. You have seen the language network revisited, the modern network revisited, the mentalizing network, and of course we have to put everything all together because we are human beings. In other words, this is the concept of meta-network. We are doing nothing, we are just watching TV. We are telling, okay, so you use just your visual, auditory, somatosensory input if you drink a gin and tonic, for instance. And suddenly, you have fire in your house, and you have to put everything all together. I know what is this alarm, my autobiography memory. I have to find a good solution, the working memory, very quickly in order to make the decision, also the different subnetworks bilaterally in order to make the good action, meta-network. And finally, you can avoid the fire. And now you are under the normal state, if I can say, you are doing more or less nothing. And you can decide of that, especially when we are doing surgery, for instance, and to continue to be very attentive. And I know some neurosurgeons not able to be attentive more than 2 hours. The next step is to dream about the brain-computer interface. Because if you have a lesion at the level of the SLF3, the lateral part of the supralongitudinal fascicle, the articulatory loop, then the patient will be anarthric, but the rest of the network is processing. So maybe we can put a probe or a grids at the level of the supramarginal gyrus, the ventral premotor cortex, which is the output, and then to resynchronize the network. Because in fact, what we are doing when we stimulate is to desynchronize not one area. I inhibit one area. No. No, we do not inhibit one area. We are eliciting disorders within one subnetwork and sometimes between networks. And we have to be conscious about that and, of course, to discuss online with the neurophysiologist and your psychologist. And finally, the patient, to answer your questions, so who are very motivated because they know that they will continue to enjoy normal life, but living definitely longer, because we should not be afraid to arrive earlier because we start to understand the principle of meta-networking brain and neuroplastic phenomenon. So if I can do that in Montpellier, you can do that everywhere, because you can do that with a super good team, but just a fork and a knife. Thank you.
One motivation of Dr. Duffau here for us is one of the take-home message is he not only spend the time doing surgery. The problem for us, all of us, Dr. Sanchez works with me and everybody here, is that we invest too much time in operating surgery, doing surgery, any case, this case by case. You see all of the slides of Dr. Duffau, all reference books, articles, many, in many important journals. And he's a young neurosurgeon compared with me. And of course, we need to learn today, how we can improve our scientific production. And that's only for surgeries. Surgery, think and write everything, and write with discipline, and try to have a team. That is why I bring Dr. Duffau here, because as he says, he can do in Montpellier, it's possible to do here in Colombia. Absolutely possible. We need only a fork and a knife. That's it. We don't need too much technology. Just dedicate more time to few things with good discipline. I think it's a good example, and please, a big applause also again for Dr. Duffau. And so maybe we have some cases to review.
I can show you how I do it. So very quickly, the setting of the operative
I think
theater
one of the things for the neurophysiologist people, sometimes they're afraid that how are the intensity for the cortical plates, subcorticals, things like that.
Practical.
Okay.
The goal is to avoid to forget nonetheless that we have to operate concretely the brain of patients, and then sometimes we have also to be connected to the keyboard, to the brain, to the techniques. But it's not the most important for me, as I have told you initially. Now, I will show you that if more or less the vast majority of concepts are clear in your mind, then you can achieve this preventive neuro-oncology with this result, so you have understood. But just a mosaic for you, it's good for the brain. I'm sorry, I will put. I like sometimes to reimpose some slides, but you see in a different setup. First of all, I will tell you that fMRI does not work. I think it's very important. Now it's very practical. For instance, you have here an fMRI showing you an activation at the level of the so-called supplementary motor area, and I'm sure that many of you already removed this area with finally recovery. Now you understood that you had a transitory decline of the interhemispheric connectivity, then re-increase. You see, everything should be linked in your brain. So that means that fMRI is not able to make the difference between what is crucial or not crucial. This is the reason why we published this atlas of crucial structures in the brain in neuroimage and not in general neurosurgery. Sensitivity, specificity. fMRI, language, correlated to intraoperative mapping. I will say it again. Sensitivity, specificity. You think you can make a decision to operate or not, or pre-planning according to these numbers, and you see it was in neurology 4 years ago. You cannot. And I don't speak about now semantics, executive function, mentalizing. So, we cannot map that. Of course they can, it's just research. We are doing that by ourselves, and we also correlated now resting state, motor and language with intraoperative mapping. It's beautiful, but you have 15% of error regarding the resting state. Oh, it's perfect to do research before and after surgery, yes. But to apply to one patient, I have 0.5% of permanent deficit, 15%. No. DTI, some history, by telling, okay, we compared with the intraoperative mapping, 80, 85%. You see more or less, finally, it's the same number, between 80 to 85. You will tell me, yes, but it's just your slides. No, no, no. Because we will invite in the next meeting, we will organize next year during the AANS meeting in Boston with Mitch Berger about brain mapping. And we will invite the senior author of this paper, Nature Communication, with, you see, so many departments in the world, not of neurosurgery, but engineering involved in how we can build tractography. And they said, the tractograms contain many more invalid than valid bundles. It's not me, it's the specialists in the world today. And nonetheless, you will come back to your hospital, you will use the beautiful brain lab station, what you want, you will put the beautiful DTI, you will use your navigation, and in fact, it's totally wrong. I'm sorry about that. I'm not speaking about brain shift, I'm speaking about DTI. Yes, Duffau is thinking that I think nothing. I show you the last paper in Nature Communication published by the specialist on this field in the world today. So you will tell me what we have to do. Awake mapping, this is the absolute truth in front of you. Thanks to neuropsychological assessment, online, adapted to the patient with cortical subcortical mapping, adapted to the willingness of the patient, the environment, and your knowledge of the cortical and subcortical anatomy, and then please again awake whatever the location, including in the right non-dominant hemisphere, because now you understood so many functions we have seen in the previous talk. Yes, it's possible to monitor that in 2D OR. Yes, it's possible to do that in so many departments in the world. Yes, you can have neuropsychologists understanding that these tasks are crucial. Yes, you can burn definitely localizationism, otherwise how it would have been possible to do 1,000 awake surgeries with so extensive lobectomies in patients with normal cognitive scores. Yes, you can remove definitely technology of your operating theater, just your knowledge of the brain. Now, we can go to the brain, to the operating theater and the brain, because you have understood everything. Example, 32-year-old, right man, with seizures, already slight language disturbances. Just with the naming, you will understand why, because I took an example, totally atypical, we could imagine for me, not at all, in fact, in my real life, namely with enhancement, with mass effect, with very big tumor, and so on and so on. I explained everything to the patient, as usual, and his family, and he told me, of course, I would like to be operated on, but I need to preserve something which is absolutely crucial for me, and I understood at that time, and I will ask you the question, why you will not be able to remove supratotally the flare if you want to be in agreement with the patient. What is the, not the risk, but the impossibility in his case if he doesn't want to have this deficit, which is acceptable for most of neurosurgeons, but not for my patients. What is the risk?
This is left, maybe visual?
Yes. Totally right. In fact, there is an invasion of the optic tract. You have a good mentalizing in your own brain. And I say to the patient, Language is not really an issue. I'm sure you compensate it because there is a mass effect also in this case, explaining why I like to see it. But by telling, you will have an myelopathy. I don't want myelopathy. You have a big tumor. It's probably high grade. I want to have a perfect normal life. I want to drive. Okay. So I will remove approximately 95% of the tumor. And then I said in my letter, I will remove 95% in order to preserve the optic tract, blah, blah. In the morning, you can see that we are on time. 7:30, the patient is into the operating theater. Lateral position in all cases, right, left. Because in fact, I have a poor mental imagery. For young people, don't worry, you can achieve my results because in fact, if you start to rotate the head 40, 60 degrees, I will not be able to see in my 3D representation in my mind of the networks what will happen 5 centimeters in the depth. While in the left-right position, I can, through the skin. You have seen that in the morning. In fact, I am like, I try at least a pilot of Formula 1 with my mental imagery, and I can look at the skin and I see the networks. I know where I have to stimulate. And this is very important because I do not stimulate a lot. And this is the reason why I have no seizures. So it's good also for anesthesiologists, for everyone, because the position is done, positioning, while the patient is still awake. So that means that he will tell us, no, the position of the shoulder is not very good. And this is very important also to avoid, you see now, tricks, that the patient is too tired too early. Otherwise, he has a risk to tell you, yes, but I have back pain. Okay, you have to write, yes, but I have back pain. And attentional processing, working memory will be more difficult. If the position is perfect, the patient will not have any disturbances regarding attentional processing. Then laryngeal mask.
This is one of most difficult for us because you have there a very nice thing to hold the arm. So we adapt here many things in order to do that to the arm. See, this holder of the arm is crucial for the position, and we don't have that. But it's easy to get it. But
you can buy.
Right
it's
now,
not
yes, no, it's not expensive. But it's an excuse, just an excuse. So, but we try many things in order to try to hold the arm. And you see, you remember that. But it's you can do it. We can do it.
I have not the habit to shave. In this case, it was not absolutely crucial, but it is for young ladies. And finally, I have 1% of infection, so that means that it's less. I had 2.5 when I shaved 10 years ago, so I think it's not really an issue. I put also a Mayfield, so that means that if you want to use nonetheless in your navigation and so on, you can. My message is to say you don't need it, but it's not against. It's just optional. I know some neurosurgeons very involved in mapping, and I respect them because they know very well the neuroanatomy, but they love also, and we discuss about that during dinner by night, to use toys, to play with toys. So be honest with yourself. Is it absolutely crucial, and then you have a problem, or is it just toys, and then, of course, you do what you want? I disagree, as you know, probably with Mitch Berger, because I will do a more extensive lobectomy in order to have, in all cases, a positive mapping. And I continue to think that if so many neurosurgeons are telling during meetings we have problems with a high rate of seizures, it's related to this concept of negative mapping, because you have a risk to increase the intensity of stimulation, while because we know that the ventral premotor cortex, as I told you, is the output, you will stimulate it by just asking to the patient to count and to move. Suddenly, he will have an arthria and a rest of movement just between 2 to 3 milliamps, and it's enough. I have no reason to go beyond, so no seizures.
This is one of the, I remember a session with Sanai that was with you and Berger, and he did conference comparison Dr. Verges and Dr. Duffau techniques. Dr. Verges did very small craniotomies with negative stimulation, which means Dr. Duffau says, okay, is open very small craniotomy and say, okay, stimulation, nothing here, I can take it. Always I see Dr. Duffau doing big craniotomies, trying to find all the positive structures with very low intensity, which is best for the patient. So I think I follow your directions, and we need to pay attention to that, because many times we try to do a small craniotomy, but it's not good for the function of the patient. So if we don't want the patient to have a seizure, it's better to do a big craniotomy and a small intensity of the stimulation.
Exactly. This is the next slide. In fact, 1 to 3 milliamps using 60 Hertz. So you can use monopolar if you want, bipolar. We can discuss about that with Lorenzo Bello, but finally we don't care because we have no seizures. And I continue to believe on the fact that Mitch can do that because he has 30 years of experience behind him. But when you start, you have to be careful about the risk to find nothing with a smaller bone flap, to increase the intensity beyond 3 milliamps and to have seizures, because at that time the patient is awake while the patient was asleep during the opening. And my trick is to wait for the awakening before to open the dura mater, because sometimes the patient could be a little bit agitated. And I had one time in my life when I was younger in Paris, the patient able to go out the midfield while I opened the dura mater, and I can tell you that it was absolutely terrible to say. Maybe I will have a big problem. And of course, in this case, the patient was again under general anesthesia. Then we put again the midfield, and we can do the surgery. So from now, from this adventure, I decided to open the dura mater just after the awakening, which is 7 minutes in the experience of my anesthesiologist. I don't say my experience, but I have 7 anesthesiologists in my team able to do awake surgery with, of course, more or less experience, but at least a minimum background, showing that on the 1,000 awake surgery we did, we had in one case, what's the name? I'm sorry. Not regurgitation, but aspiration in one case. And the patient spent 2 days in intensive care with antibiotherapy for 7 days, and that's it. So the real permanent negative consequence related to surgery from 1,000 awake surgery is 0. So I cannot tolerate when anesthesiologists are telling, no, I don't want to do that because it's too dangerous. You have evidence-based medicine in front of you. It's not dangerous if they want to learn. It's just dangerous in their hands, and they have to admit that. And then you have to change your anesthesiologist, if you can. So that means that now the patient is awake. You identify the negative motor network and the so-called Broca's area, which is in fact the ventral premolar cortex. The patient, okay, and you had the speech arrest, the arrest of movement, and you can use this intensity, these parameters at the level of the other cortical part and the Y matter tract. This is a very frequent question. Are you changing the parameters at the level of the Y matter tract? My answer is no, the same. And it works in 100% of cases. I have a positive mapping in all cases. Subpial dissection. You will see in movies that I will use the cortical bipolar, not just for mapping, but now I'm speaking about the coagulation, because I have understood that it was a negative area, truly negative area. And you see that I disconnect the lobe. I will leave this part, in this case, for instance, the temporal lobe, into the contact of the dura mater, because I don't need to remove it under general anesthesia because I have disconnected. And I will do a subpial dissection from now. I mean, you will see that never I coagulate. And this is the reason why I have no spasm, especially during the paralimbic tumor. because I will do subpial dissection without splitting, as I told you, the Sylvian fissure. You have movies if you want to see in the end, specifically at the level of the insula. And finally, so I will write within the insula, and I will remove it from inside by doing subpial dissection without any coagulation. So papaverine does not exist in my operating theater. Never you saw me telling, in the end, I will put papaverine. I don't need it. And if I don't need, you don't need, because subpial dissection means that you have no bleeding. And now the most important part, of course, the white matter tract. In this case, we have seen that. You remember it was the neuroscientific part, but in fact, it's typically what we are doing into the OR, namely the inferior fronto-occipital fascicle, the arcuate fascicle posteriorly, and you write the optic tracts. And in fine, you preserved all vessels, all, including veins, of course. You have the cortical mapping, the white matter tracts. How do you want to go beyond that? And of course, some visitors, because I have visitors every week also when I am into the operating theater, are telling me, but now it would have been interesting to do an intraoperative MRI just to check if there is a residue or not. And in this case, I'm sure I answered, I do not remember, this is just the concept, but I know that I left a residue because I saw that on the preoperative MRI. And the patient told me, I don't want hemianoptia. So why to use intraoperative MRI to tell you you have 3 cc of residue? You can see it. And of course, most of the time, they no, I see nothing. This is your problem.
One question.
Yeah.
In order to locate the optic radiation,
Yeah.
what is the best way to know exactly that we are there? Because this is one of the crucial things on this soil.
I agree. I did not show the slide because too many slides, but we have the habit, please stay like this, it's perfect, to have a red cross in the middle, and of course the neuropsychologist, stayed, it was perfect, to do the tasks. I'm sorry. Yeah. It was perfect because a good illustration of what we are doing. So you have the red cross, and the patient has to see 2 pictures. For instance, a mapping and a fish. And to say mapping, a fish mapping. And then you change, and you will continue to say this is a dog and a cat. And suddenly the patient will tell you this is just a house. And where is the car? So it's not a problem of understanding, it's not problem of language, of naming, it's problem of vision. But be careful, because in this case, the neurophysiologist or the neuropsychologist had to be very careful, because the patient can do a saccade very quickly. And then it will give you, in fact, a false positive answer. And then you can cut the pathway because you believed that the patient was still able to continue to see in the both visual fields. So you need to rely on your neuropsychologist. So in this case, you can put again the diaporama, please. Thank you. As most of the time, as you have seen, especially in big tumors, you have the habit to hear that wake surgery is so long for 1 day. It's not compatible with a normal activity of department of neurosurgery. More or less every day at noon is finished. So that means that if you want to do 10 lumbar discs in the afternoon, you can. No clinical worsening in this case, and especially no hemianoptia. Language is proved spontaneously, of course, because there was also mass effect and not just invasion in this case. And I have the habit to keep approximately the patient for 4 days. Why? Because one night in intensive care, the day later the patient will be in his room, and the goal for me is to push the patient to walk and so on. He will benefit from post-operative MRI within the 24 hours in order to be objective and to calculate so objectively the volumetric assessment. 2 days later, we will have the neuropsychological assessment in order to guide the post-operative cognitive rehabilitation. And 3 days after, we will have the results of the neuropathological examination. So that means that before the discharge, we have everything.
3 days after the lambia.
Sometimes 2.
I
think it's possible.
The air conditioner is too cold.
I agree. I agree. I agree.
Paying attention to the air. I'm asking you. Sorry.
No, it's okay.
I know you that when you were working at the Neurological Institute, you have review of the pathology within the subject. I remember that when I was resident. But right now in Colombia, we have a big delay to pathology results. More than
I know we have many problems. The first is we don't have very strong molecular studies. That is the one. The second is our health system in Colombia use only general pathologies. There aren't neuropathologists, and the general pathologists don't nothing the neuropathology, nothing, are almost, I say, bestias. You know what it means?
I understand very well.
Okay. Meaning stupid. And there are very difficult to the classification in the last way in the diagnosis and in the pathology. That is a big problem. Are very few because the health systems only pay general pathology to do many work. It doesn't matter if it's okay or it's wrong or mistake. It doesn't matter. That is the problem in Colombia. Neuropathology is like the dinosaurs. Don't exist.
This is the reason why I told you
extinction of species.
Ago that I loved, in fact, a neuropathologist because I have the chance to continue to work with one neuropathologist, seeing more or less 300 brain tumor a year. So that means that she has this experience. And we agree when I say that we have to develop department dedicated to this kind of management, and it's not only true for neurosurgeons but also pathologists and or radiologists or neuropsychologists and so on. So I rely only on some pathologists, on some neuropsychologists, and on some anesthesiologists. But this is the dream team, like Madrid. This is the reason why we can become a world champion, only if you have the good guys.
On another question, speaking on this case, I remember that you tell me many times, I hope that the patient has some, for example, in motor area, some weakness.
Yeah.
If you have some weakness, I know that I did a good job.
Yes.
And the people that is observing many times in my surgeries, for example, say, oh, Vargas say that he's doing monitoring and the patient is weak.
Yeah.
So did a bad job. So please explain that. The patient is going to recover if you know where we are.
You're totally right. If you push the realization according to functional boundaries, you will have in all cases an edema, a swelling, a modification of the network, as we have seen thanks to pre- and post-operative resting state theory of graph. So that means that if the patient is too well following surgery, you left a margin around the connectome. And in this case, of course, maybe some radiotherapists can say, fortunately, I was there to irradiate, which was, in fact, resectable. Because if you push until the functional boundaries, I mean just 1 to 2 millimeters, the patient should worsen for the next days, and then should benefit from this post-operative cognitive rehabilitation. And you will say, finally, 5 millimeters around is nothing. But please calculate just mathematics, geometry. 5 millimeters all around the cavity, it's 30% of the tumor. So that means that, in fact, you did a partial resection. And you will say, no, Duffau is telling something totally wrong because I'm not able to achieve 15 to 20 years of median survival. Of course, you left 30% of the tumor. And I saw so many neurosurgeons in my life telling, really, honestly, no, not 30% for 5 millimeters around. But you remember when we were at school, we calculated the volume, and in fact, the volume in the middle is nothing, but more the tumor is big, more the volume is big, more if you leave 5 millimeters, you will leave finally 30 cc. Oh, really? Of course, really. So, be objective and full of common sense. And this is the reason why my patients are the first to tell me, sometimes in intensive care the night of surgery, probably you made a mistake because I am too well. So that means that they understood the principle. And very quickly, they are frustrated to be well because probably you leave too much tumor. And sometimes I say, no, I'm sorry. I did a supraarteriorization and you are well. I don't know why. I have something to learn from you about the brain. But in 90% cases, they are not so well following within the day following surgery. And of course, you have to inform the family about that. Otherwise, they would like to kill you following surgery by telling it was incidental discovery. You have seen my daughter. She's 20 years. She was perfect. And now she has a big bandage and she is totally aphasic. No. Don't worry. She will recover. How you know that? Because in the end of surgery, when I stopped the realization according to functional boundaries, she was perfect. So just edema. Maybe it's a stroke. No, because I did postoperative MRI. There is no stroke. So I will tell you now, rehabilitation. So in this case, as you have seen, we left exactly what Dr. Vargas has seen. So that means that you have, once again, a good 3D representation of the brain. It was not possible to remove that. It's possible, but I will induce hemianopsia. And the patient told me, no, the patient is the boss. So you have understood why you can have this reliability, again, some redundancies voluntarily, and you can use this plasticity phenomenon. I'm sure that I have convinced you, but with some limitation in the depth, the connectivity. So be a neuroscientist, and if you want, do a PhD in cognitive neuroscience in order not only to learn that, but to go beyond. Now, an example with movies, as promised. A young girl, medical doctor, there is no coincidence. Why? Because she was working in another hospital. The neurosurgeon is very good, able to remove all tumor, blah, blah. But finally, because she was a medical doctor, 23 years, so chief resident and so on, and within the so-called Broca's area plus the insula plus a little part of the temporal lobe, not seen here, not shown here. He said suddenly, no, it's too dangerous. I don't understand. You're a real neurosurgeon or not? So you see that emotional process in the brain of neurosurgeons. So we are, first of all, emotion. And I can understand that. So we have to apply that to the patient. Of course, first question of the patient, you sure I will not be aphasic hemiplegic? Not sure, but 0.5% of risk, blah, blah. You think I will continue to take care of my patients? I need theory of mind, empathy. Yes, we will map it, and so on and so on. So, in practice now, wide band flap, lateral position, you remember the ears with the computer is there, the posterior part is there, the temporal lobe, the frontal lobe, and the Sylvan Fisher with the ventral premotor cortex, because the precentral sulcus is there, the central sulcus is there, this is the precentral gyrus, and of course I have asked to the patient now awake to the movement and just to count, she blocked at this level, and what happened at the level of, I do not remember the name, Broca's area, I think, and the pars triangularis and orbitaris, nothing, strange. You don't see that. You see, he asked the question and now he don't see the, I don't understand that. Finally, we identified the dorsolateral prefrontal cortex, the posterior part of the junction between F3, F2. You remember, so the I4 is there, running to the semantic area. And everything is clear because, of course, we did naming task, but also semantic association task. We did mentalizing task, and so on and so on. And the patient is doing that now. And then I use, of course, bipolar coagulation because I have no risk at this level. But as you will see, I will do now a subpial dissection by preserving here the ascendant ramus of the Sylvian fissure, plus of course the Sylvian fissure itself. So I will do now a subpial dissection, and I will never coagulate, never. You can do this kind of very extensive resection with no bleeding. And of course, I do that without microscope. Otherwise, I would be tempted to coagulate, which is a big mistake in the brain. And second, because I will not see what I will do in the depth. And at this moment, what you should think about is the IFOF. Except the fact that you are protected by the surface of the insula. I am not yet into the contact of the surface of the insula. So very quickly, it's more or less real time. I will disconnect this part of the lobe and everything will go to the lab. And then you can analyze if there was a focus of malignization in the middle or not, and so on and so on. So that means that the goal is not for me to remove the anterior part of the frontal lobe. I will do that under general anesthesia in the end once disconnected. But the goal now is to see the surface and the insula. And you can see the cortex now with the vessels. And this is the superior circular sulcus. So at that time, be careful, because you have to go within the insula and to, of course, think about the connectivity. But think about this connectivity means that you know your anatomy, and not just speaking about the IFOF, the function, the semantics, and so on, but to see in your mental imagery, this is the reason why I will put a retractor, to see the surface of the insula, and in the depth, the IFOF is running in the temporal stem, namely the lateral part of the anterior perforating substance. You should see that in your mental imagery, otherwise don't operate the brain, because that means that the temporal stem will protect you from the anterior perforating substance. And you see now I use the retractor to lift up the cortex of the insula. I will do that again. I removed a little bit more tumor in order to have a good view. Just with my glasses, that's enough, and the knowledge of the functional anatomy, and the fact that the patient is doing the tasks online. And of course, again, I will do the resection of the insula by lifting up, you can see the surface of the insula, the circular sulcus, and by doing a subpial dissection from inside. That means that never I will be into the contact of the vessels, never. So why do you want to have any vascular problem? Because it could be anterior perforating substance, but you will protect it by the IFOF. So now you can remove the insula from inside, just without microscope, without near navigation, without robot, without intraoperative MRI, without electrocardiography, without, okay, you have understood, without coagulation, without CURSO. And now be careful, because you should see the IFOF. The patient is well, yes, no semantic paraphasia, no. Switch with the PPTT, you sure? No semantic? No semantic. Okay. Dual task? Yes. Finally, I remove just a little bit of the temporal lobe, and now I will stimulate. And you see that more or less I do not stimulate. And now, semantic paraphasia. Okay, I have understood. I am into the contact of the ventral semantic pathway, and at that time I didn't need intraoperative MRI to know that I have to stop. Otherwise, I will cut the IFOF. Now the patient is awake, is under general anesthesia, and then I can finish this resection because everything is disconnected. And of course, never I will go back or in the depth, just anteriorly. You see that never I coagulated, except the cortical surface. Never. You have not to coagulate.
Some stupid question from the pathologist.
Yeah.
In the resection, the tissue appears different from the normal tissue?
No, just the bulky part of the tumor, but not in the periphery. So that means that this is the reason why we cannot feel the tumor. I know that all neurosurgeons told you I can feel the tumor. No, they feel nothing.
The brain tissue is very soft and
yes,
elastic, but the tumor is more elastic but not hard.
In the middle, but not the periphery. And the goal is once again to try to remove more and not just what we can feel. Of course, some neurosurgeons, including me, sometimes you have rubber. So you don't need to be an expert to know that it's tumor. But we don't care. This is the periphery, which is very exciting to remove. And this is the reason why you will see the postoperative MRI. Now, it's not my imagination. I was into the contact of the extreme capsule with the inferior fronto-occipital fascicle, the lateral part of the lentiform nucleus. Of course, I removed Broca's area because Broca's area does not exist. The patient is well, and I left a small but objective amount of tumor, you can see it, into the anterior perforating substance, because I don't want to take any risk at the level of the perforating arteries, because the big neurosurgeons didn't want to operate this girl because it was too dangerous. It's not dangerous because I will be reasonable by telling I will leave 1% of the tumor. And I know that I will not cure her, but she's now, with 5 years of follow-up, becoming a medical doctor with the thesis, and so on and so on. So enjoying a perfect normal life without any chemotherapy, and of course not radiotherapy, which is forbidden. Now you start to understand why. And to be honest, there was already a focus of malignant transformation in the middle. She is in the series which will be published in Neuro-Oncology with the foci of high-grade transformation, and never she received any adjuvant treatment. I don't know if you want to see a last video or not, to see also the limitation of surgery with sound now. So now we will have audio also, and it's very exciting because we will write paper to answer also very practical issues, because we are draining many patients coming from different countries and continents. We need sometimes to use a translator into the operating theater because we can speak more or less English, French. My speech therapist is able to speak Spanish, so we can cover more or less 80% of the patient, but 20% are speaking another language. And when we map different languages, you have seen that, maybe it's not so complex because we can speak at least or English or French or Spanish. But sometimes patients are just speaking their native language, and we can understand nothing. Sometimes it's not so far, like Italian, for instance, because we have the same root. But when a patient is speaking Russian, for instance, I can tell you that I understand absolutely nothing. I mean, including the prosodia. So we need translator, and to train the translator. And just to tell you that in our paper, we will report that we did that in, except the 3 languages I spoke about, 17 different languages. So you can imagine that the question is frequently raised, yes, but if we start, for instance, to have a patient coming for you from Portugal, because this is the case, from Brazil, but speaking Portuguese. So I'm sure that you are able to understand Portuñol. If I am well understood, you have some mix. But nonetheless, for us, it's impossible. And this is the reason why we had a translator, which was in fact a neurosurgeon, a young neurosurgeon from Brazil, speaking, of course, Portugal, and able to help us during surgery. So you will have also audio. I'm not sure it will work, so I will use directly the video from, not from the PPT, but the original video I have checked before. Okay. I think you can, yes, the sound a little bit more. So you can see 30-year-old woman, right-handed, so medical doctor, again, I have really a bias in my recruitment in Sao Paulo. So speaking only Portuguese, I'm sorry. And you can see, so this very invasive tumor, you have seen very quickly, probably, I'm sure, the arcuate fascicle, the SLF. And we have to be careful about that. So the patient was not shaved, as I told you, an awake, asleep, awake procedure. You can see that she's in the left position. And we use propofol and remifentanil for just the opening and the closure. And I can use, because I have visitors, and to show that you can have an intraoperative MRI. You can see the Sylvian fissure, the tumor at the level of the operculum, a part of the invasion of the insula, the superior circular sulcus, so everything is very clear. You don't need, in fact, intraoperative MRI, even speaking about the delineation of the tumor. So that means that You can do that everywhere with very cheap equipment. And to me now, it's not absolutely mandatory to use ultrasound, but I think it's a good training. So, and it's good for the psychotherapy. You use it just 30 seconds in order to be sure that you are in the good place and so on. So first step, again, counting with movement in order to have speech arrest and the arrest of movement too. And as usual, 60 Hertz, 1 milliamps, and we will increase very slowly, but never above 3 milliamps. So no seizures. So you can see that the patient is well, no complaining, no pain, blah, blah. The rate of surgery, awake surgeries, we had to stop about 1,000 awake surgery because the patient said, no, it's terrible, stop, is 0. So I do not believe, I will use this term because many colleagues are telling that it's not possible to operate a patient under awake mapping. I don't speak a patient already aphasic, hemiplegic, of course, or children. I'm speaking about adults. So the lateral part of the ventral premolar cortex, and finally, so the patient had, it was totally expected, a speech arrest and arrest of movement. Because now you have understood the principle of the FAT, the frontostriatal tract, the SLF2, with the loop between the supramarginal gyrus and the ventral premolar cortex. Of course, Broca's area is not involved in this network. You can, now we will listen to the patient. No.
He doesn't have a sound from your computer.
Of course he had, because we have tried 3 hours ago, and you told me everything is okay. You see why I hate technology? Because 3 hours before technology is like, yes, this is the same movies, the same computer, I did not disconnect, and 3 hours later, no, finally we have a problem. If a neuroradiologist told me that during surgery, I will kill him. No, I am not patient. I want to go fast, to be focused. You see, it's a part of the answer also to your question. In fact, I have no time into the operating theater. It's Formula 1. You need 1 to 2 hours. It's limited in order to win the Grand Prix. Otherwise, you did not perform the job. Nonetheless, it's not really an issue, I'm sure. Don't worry about that. Because you can see the patient online also. You can see that the patient started to have naming arrest because everything is shown on the... And then I will put the positive number. I don't use... don't touch my computer. Okay, if you want, but... I don't understand why, because you explained to me that HDMI was enough. Yeah. You see that the patient... We have not to be disrupted. During surgery, the patient is doing dual task, so speaking Portuguese with online translator, and of course the neuropsychologist who is there in order to be connected on together. And that means that, of course, I will continue, in her case, the cortical mapping in order to identify the left pars opercularis. You would like to have a proof. This is the so-called Broca's area. I'm sorry, of course, the Sylvian Fisher, so the pars opercularis and so on. And there is no tumor at this level. And what happened? Nothing. It's not my imagination. Hundreds of patients. So Broca's area is not the area of speech. And this is the reason why now I will remove the so-called Broca's area, because invaded left pars opercularis and triangularis. And of course, the patient continues to alternate between the naming task, the PPTT, with translation online, the movement, dual task, every 4 seconds without any rest. So sustained attention, divided attention, language, understanding, movement, and movement control. Okay, perfect. Now we can remove, not the tumor. As you see, finally, you see nothing. It's just like brain, but the brain itself, but invaded by the tumor. So I will coagulate, but just the cortical surface once again, and then to do the subial dissection into the contact of, no coagulation inside the pia mater. Participation is required. I have the habit to tell them during the first meeting, I am a coach. I need your collaboration. You will not disappoint me during surgery. I hate to lose. We will win the gold medal, and so on and so on. It's really a coach, and that works. This is the reason why the aborted surgery, about more than 1,000, is 0. And at that time, I will use, again, the same principle of retraction, you remember, in order to have an access to the surface of the insula and finally the fibers. And then you can see the cortex of the insula, the superior circular sulcus, the insular vein. Circular vein. You don't need microscope to see that. You don't need to coagulate. You do just a subpial dissection. No microscope, no spasm, no papaverine, no coagulation. You have understood? This is the surface of the insula with M2. M3, if I can do that, you can do that. No robot. You did something, no, it was not a good idea because it continues. Sorry, I hate really technology. Do nothing, it's perfect like this. But now, thank you. I'm not patient, you see, because I'm really doing the surgery now. I'm like into the OR. Everything should be perfect. I need your help during approximately 5 to 10 minutes. You see, I have to motivate the patient. I need help. You will help me. Everything is okay for you?
Okay.
It becomes a little bit difficult to have this awareness. So this is the reason why we will just check now if everything is okay, but probably we will stop in a few minutes. Okay?
Okay.
Just to validate now.
Isso é limão. Isso é avião. Isso é uma bandeira. Isso é leão. Pentear o cabelo. Isso é canguru.
Go fast. You stimulate, nothing happen, you can continue.
Isso é canguru.
At that time, he told me, because once again, translation, perseveration. Oh, no. Okay, I understood. Semantic prophagia, perseveration. I am into the contact of the eye. I will stimulate again.
Isto é uma feira. Isto é uma vela. Isto é acordeon.
1, 2, 3. The same parameter.
É
never
cavalo.
Yes, 1, 2, 3. According to the parameters I have identified at the level of the cortex. The same. Similar. We changed nothing.
Regador de planta.
So now I identify the I4, but I have also the SLF. Ventral semantic pathway, dorsal pathway. So you see the research is really into the opportunity. So here I can continue. I'm very close, you see, to the ventral premolar cortex. So I know this is the SLF. 3. I will not remove completely, but I can push.
Isso é uma cama. Isto é
Okay, you have understood. You don't need car pattern, right? There is a residue, and so what? I will cut the pathways.
Aspirador de pó.
So I5, SLF3. What we have seen in the previous talk, I tell you, no, it's too much, it's just neuroscience. No, it's exactly what we have in front of you, because we cannot see the tumor. And then more we remove, more we increase the median survival, but not against the quality of life.
Okay.
So in the end, please, the patient, we checked, and of course we removed Julian, can you hear me?
Yeah.
Everything is okay for us.
Yeah.
Can you tell me your name, please?
Juliane.
Yes.
Isso é telefone. Isso é limão. Isso é avião. Isso é leão. Isso é canguru. Não.
D'accord. Okay. Un petit dernier. The last one, please. You're never disappointed by the brain. It's not the same thing with technology. Okay, you performed a great job. You will recover, but I think it's not reasonable to push the resection more because you have seen that it was a little bit difficult now. So we will stop here. Okay? Translation online, Portuguese.
Okay.
Congratulations.
Thank you very much.
So speaking just a little bit English, but not enough in order to do this kind of task with a high level of reliability. So you can see I was really into the contact of the IFOF and posteriorly the SLF. So it's not my imagination. But we removed the, what's the name? Broca's area. She's a medical doctor. She didn't know that Broca's area was not the area of speech because she's still a medical doctor. And deal with cortical plasticity, which is not an issue, but be careful about the deep connectivity because at this level, I stopped. The patient is enjoying, that's true, a normal socio-professional life as a medical doctor, able to drive, no seizures anymore. So we improved the quality of life, and of course, no chemo radiotherapy. And the next step will be, in her case, chemotherapy, because I will not be able to cut the IFOF and the SLF. So I know that the residual tumor will continue to diffuse, to migrate, and then we will do chemotherapy in order to avoid to irradiate both the ventral semantic pathway and the dorsal pathway. My radiotherapist are able to understand that, but I hope that now it will be true also in South America. Thank you very much.
We have a very good time. It's right now 7:25. Raúl, do you have the... So please feel, we are going to put some questions, very quick questions about this course. Please enter with your telephones to this link and answer the question about the course. Please, right now, enter the link right now. Please enter the link that we're going to put there in order to answer if the objectives of these lectures were well or not. Please qualify that. You can do,
the last one, I'm sorry.
You can do,
for you
they
too.
can enter with this. They enter the link. Scan, oh, you enter the, yeah. Please answer the questions, please, right now. So we are using this. They enter the questions, 1, 2, 3, 4, 5. And then at the end, we take a picture, please. Before we leave, we take a picture, everybody here. Picture. Answer the question. Use your phone, scan. Everybody has the Pipe, ¿cómo se dice encuesta? Pipe, ¿cómo se dice encuesta? Encuesta, survey. Remember that at the beginning we have objective of the course. Yes, if the person don't. To understand the natural history of diffuse low-grade glioma and the impact of early and maximal surgical resection with the wave mapping of this tumoral course. That's the first objective. To incorporate brain connectomics and neuroplasticity in the management of the low-grade glioma patients, opening the door to the concept to the oncofunctional balance. To know the improvement of the long-term oncological and functional outcome in low-grade glioma patients who benefit from a multi-stage and individualized therapeutic approach leading to the purpose of screening the general population. ¿Lo lograron o no? De tecnología. ¿Sí pudiste? RH está diciendo que va a preguntar. Usted puede preguntar en el sistema, ya en la pregunta, ahí le están preguntando que si va a preguntar algo. ¿Lo puede poner al aire a él? ¿A RH? Ya le vamos a preguntar. solicite la llamada. ¿Usted no lo puede llamar? Levante la mano. We have one question from Boston, please. Wait. Habilite su micrófono para que pueda hablar. Si lo pongo en este micrófono, pero ¿cómo le hago una llamada a alguien que tiene un iPhone? ¿Pero cómo? ¿Pero cómo lo puedo yo llamar? Es que no tengo él me llama a veces como por un... Pipe, ¿cómo puedo llamar aquí a Rodolfo? Como por un audio message o algo así, audio, no sé qué. Es que él no tiene WhatsApp. Por favor, los de Bucaramanga podrían, para llevar a todos al restaurante Puerta del Sol. ¿Quiénes van a ir? ¿Todos? Sí, sí, foto. Ah, los tres. Hello, Dr. Rodolfo, we're hearing you. We have here Dr. Duffau hearing for your question. Could you please tell the question, please? Dr. Duffau, this is Dr. Rodolfo from Boston.
Hello?
Hello, do you hear me?
Hi, yes, I can hear you. Can you hear me well?
Yes, I can hear you. How are you?
Okay, how are you? Thank you. I enjoyed very much all your talks. I just had a simple question. When you were talking about that certain specific areas change, they migrate because of the tumor, I was curious, does the pressure induces change of location, or is it a chemical? Is it induced chemically, or what makes these areas change with time?
It's not related to the pressure, but to the invasion progressively of the networks I spoke about, because you have seen in the second talk that these networks are bilaterally organized. So that means that you can have a modification not in one area, but in fact in hubs which are constituting this large-scale network, and with modification of the weight of each hubs, cortical hubs, related to the invasion of the brain itself, and especially of the white matter tracts. Plus the fact that you can induce this plasticity also by removing a part of the brain during the first surgery, and by doing by yourself the post-operative cognitive rehabilitation, so changing the connectome, as we have seen, using pre- and post-operative functional imaging, modification of the theory of graph and the interhemispheric connectivity. So to tell you exactly, of course, the microscopical mechanisms, I will not insist about that, but we will have modification of the weights of the synapse. You have also some neogenesis, which is possible, and so on and so on. So I did not speak about the ultra-structural mechanisms. But remember, when I spoke about the insula, I said also that before any surgery, you had a modification of the morphology of the contralateral insula, which was already a little bit more big. So that's true for the insula, but for other area also. So that means that you see, you have in fact a complex phenomenon, not only related to the structure, the function itself, but also the structure. So we can definitely forget the principle of mass effect, except of course in high-grade glioma, when the patient is more or less aphasic, related to a very big tumor, and then you decompress and the patient will improve. But it's not reorganization, it's just relief of mass effect and edema. But here I'm speaking about patients with more or less normal examination before and after surgery, and then reorganization within this meta-network. So I hope we will continue to better understand these mechanisms thanks to more longitudinal functional imaging before and after surgery, but also before and after rehabilitation, and before and after chemotherapy, because sometimes patients are improving when you have a shrinkage, especially at the level of the white matter tracts. So you see, it's really a longitudinal process, and you can, of course, especially in Boston, you have very good functional imaging, participate in this kind of serial functional imaging throughout a chronic disease.
Rodolfo, are you there? Hello?
Yeah, I lost. I can see you, but I can't hear you.
Perfect.
Okay. Okay.
I can hear you in the computer.
So you, but no. I mean at the phone, by phone, you hear? Okay. Did the answer was okay for you?
Yes.
Okay. Okay. Do you have another question?
No, that was great.
Okay. Thank you very much for the participation.
Thanks a lot.
Thanks. Bye.
Bye.
Okay, we're going to take a picture, please, everybody here.
Desde las modernas instalaciones de la Universidad de Santander, en la capital del departamento de Santander, la ciudad bonita de Colombia, la ciudad de los parques, transmite UDES Radio Bucaramanga, su emisora online, estación de radio al servicio de sus oyentes. UDES Radio Bucaramanga, su compañía ideal en todo momento. UDES Radio Bucaramanga, emisora de la Universidad de Santander UDES, donde está su mejor proyecto de vida. 37 años contribuyendo con la formación de la juventud colombiana. La calidad nos une. Universidad de Santander UDES, su universidad internacional.